We are live now, ma'am.
Yes, you can start. You can start, Bhavna.
Yes, ma'am. So, very good afternoon now, ma'am. A very good evening, respected faculties. On behalf of Corona Remedies, I welcome you all for today's AMOGS Medical Disorder Committee, a mixed bag webinar.
You can start, Bhavna.
Yes, ma'am. So, sorry, there was a voice breakage. Yeah. So, good evening, respected faculties. On behalf of Corona Remedies, I welcome you all for today's AMOGS Medical Disorder Committee, a mixed bag webinar. Today's conveners are Dr. Suman Sinha, Dr. Supriya Jaiswal, and Dr. Indrani Roy. Dr. Suman Sinha is a President Ranchi OB-GYN Society, Senior Consultant at AHIVF and Infertility Research Center, Ranchi, Director Advanced Care and Maternity Center, Ranchi, Vice President SOVSI, Bihar and Jharkhand Chapter, Executive Member Urogyne Committee, FOGSI, and Executive Member National ISOPAB. Dr. Supriya Jaiswal is Vice President Patna Obs-Gynae Society, Chairperson Adolescent Health Committee FOGSI, Joint Secretary SOVSI Bihar and Jharkhand Chapter, Chief Consultant at M Hospital Patna.
Thank you.
Dr. Indrani Roy is Senior Consultant and HOD Obs-Gynae Nazareth Hospital, Shillong. She is President SOGS. She was President SOGS in 2017 to 19, and she was organizing chairperson National Yuva IH in 2022, and she is currently the member of Breast Committee FOGSI from 2022 to 2024, and she is also a DNB teacher. Welcome, ma'am. So before going ahead, let's begin with a small prayer.
The volume.
Can't hear.
Mahaka Suryakoti Samaprabha Nirvignam Kurumede Sarvakaryeshu Sarvada.
Now, I request Dr. Suman Sinha to please to take over the session and please introduce our guest of honors.
Thank you. Good evening, everybody. Thank you, Bhavna ji, for your kind words. After invoking blessings from Almighty, we are going to start the inaugural function. Share your knowledge. It is way to achieve immortality, quotes Dalai Lama. And imbibing this philosophy, I take the humble opportunity to welcome all the dignitaries and our esteemed guests to this webinar, which is in association with AMOGS Medical Disorder Committee and Societies of Eastern part of India. At the very outset, I welcome our revered guest of honor, Dr. Rajendra Singh Pardesi, sir, our luminary President-elect, Dr. Jaideep Tang, sir, Dr. Gokul Chandra Das, sir, and Dr. Sunita Tindalwarkar, madam. They all are teacher of teachers, surgeons of par excellence, friend, philosopher, and guide to many of us with phenomenal services towards Foxy and our nation. I welcome a very talented and experienced speakers and moderators, Dr. Arun Madhav Barua sir, Dr. Samal Seth sir, and Dr. Sneha Vihar madam, for accepting our request and very meticulously preparing the subjects to update us in the recent advances in obstetric and gynecology. I welcome our experienced and learned chairpersons, panelists who will enrich us with their valuable inputs. I welcome all the delegates who have joined us, and I'm sure they will be updated and enriched in the end. I welcome all the members of our team for their untiring effort in making this webinar a grand success. I think and feel obliged to our academic partner, Corona Remedies, for the digital platform. Now, I take the pleasure to invite our program director, Dr. Sneha Vihar madam, for the official welcome address. Can I have Madam's CV? Madam Sneha Madam CV. As we all know, Madam is well known to all of us. She has been the very dynamic past chairperson breast committee Foxy, and presently she is the chairperson of medical disorder committee of AMOX, and she is also the present governing council member, and she has a huge experience of more than 30 years in obstetric and gynecology, and she is recipient of numerous awards and accolades. Her kitty is full of those awards, and I request her, Madam, for the official welcome address and also to introduce all the guest of honors. Welcome, Madam.
Thank you so much, Dr. Suman, for that kind introduction. A very good evening, respected Dr. Rajendra Singh Pardesi, sir, Madam Sujata Dalvi, the President and Secretary of AMOX, Dr. Jaideep Tang, President-elect of Foxy, Dr. Gokul Chandra Das, Dr. Jaideep Tang, who is at present busy in a government meeting at Delhi, and he will be joining soon. Dr. Gokul Chandra Das, who is at Puttaparthi, he will also be joining soon. He is the President of Association of Obs-Gynae of Assam and Northeast. Madam Sunita Tanduladkar, who has just joined, who is the brain and beauty, and you can see her extensive campaign for the presidential elections. At the outset, I would like to thank and welcome all of you for accepting the invitation to be on this program and grace the occasion. I welcome and thank all the AMOX office bearers, especially Madam Nandita Palshetkar, immediate past president, Dr. Kiran Kurtakoti, the president-elect, also Dr. Ajay Mane, who is the Foxy vice president-elect, ICOG chairperson, Dr. Lakshmi Shrikhande, and secretary, Dr. Ashok Kumar. Speakers for today's program, Dr. Arun Barua, who was also my committee advisor. Our dear friend, Dr. Samal Seth, who is just recently got elected unopposed for the post of Vice President Foxy. Respected Dr. Apurba Bhattacharya, dear Dr. Nilakshi Fukan, all the dear panelists, Dr. Shailinia, Dr. Arindam, Dr. Jupirika, Dr. Himlina, Dr. Nilotparna, Dr. Pranabika Mahanta, Dr. Sharmishta, and my dear friends, conveners who are so long been associated with me, especially Dr. Indrani Rai, who was the East Zone coordinator of my committee and has done tremendous work for my committee, Dr. Supriya Jaspal, a very sincere, hardworking girl, and Dr. Suman Sinha, who is also a very dedicated, hardworking Foxyan, who is also contesting for the post of chairperson Foxy for the vaginal surgery committee, and all the viewers. I welcome all of you. The program you can see here, we have planned it for hypertensive disorders of pregnancy. As always, I say that, in spite of having so many predictive factors, including the maternal characteristics, the HDP gestational score, and so many other biophysical and biochemical markers, the incidence of complications related to HDP, they are not on decline. In fact, they are still the same, and the maternal mortality which is associated is still not declining to a significant level. And that is why there is a need to communicate a sense of screening for the medical disorders, including hypertension disorders of pregnancy. And that's a very humble attempt to organize such kind of CME, which will sensitize the Foxians and also for the screening, early diagnosis, and prompt and effective management of hypertensive disorders of pregnancy. With this, I wish best wishes for this program, and I wish all the attendees, I'm sure you will have a great learning here. Once again, I thank all of you. And now I take this opportunity to invite AMOG's President, Dr. Rajendra Singh Pardesi, for his blessings and precious word. All of you know, sir is a very illustrious person. He's a very humble and very straightforward person. And sir was a vice president of FOXI and chairperson of FOXI Food and Drug Committee. So we are very eager to listen to your precious words, sir. Over to you.
Good afternoon, everybody. Respected chief guest, Dr. Jaideep Tang sir, Dr. Gokulda, Dr. Sunita Tandurkar, and our ever active AMOG secretary, Dr. Sujata Dalvi, Dr. Ajay Mane, and with our AMOG's office bearers. I am feeling proud and honored to be a part of this webinar headed by three giants. As Dr. Sneha told, really there are three giants in their field, Dr. Jaideep, Dr. Gokulda, and Dr. Sunita Tandurkar. To listening to Dr. Sunita Tandurkar, and each and every talk is really different every time. She is master in that. And with all these, Dr. Arun Barua, Dr. Shamal Seth, Dr. Indrani, Dr. Supriya Jaiswal, Dr. Suman Sinha, Dr. Nilakshi, Dr. Manjima, Dr. Apurba, and panelists, all are known to me. Means Shalinina, Himlina, Arindam, Nilotpanna, Chupirika, Pranabika, Sharmishta. When I attended NeoGISCON also and Guwahati, and even AISUG 2010 Guwahati. So they are very close to my heart, all Northeast and all those. So I think with the galaxy of these speakers, this will be a really great program, which includes anemia, means FCM in anemia and all those, IUGR, SDP. To say a few words about Dr. Sunita Tandurkar and Dr. Sneha Buyar. Dr. Sunita Tandurkar and Dr. Sneha Buyar, they are the pillars of our AMOGs, and they are contesting for elections. We wish every success to Dr. Sunita Tandurkar for her election as President FOXI, and to Sneha Buyar as Vice President FOXI. And with this, even Dr. Suman Sinha, she is very active FOXIan, hardcore obstetrician. We wish every success to Dr. Suman Sinha for her chairperson election. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Sneha madam, can I request you to introduce Jaideep Tang sir? He will join and then he will give his blessings.
Yeah, I think we will have his blessings and words after he joins. I think we can go ahead. Madam Sujata Dalvi has not joined. Yeah, Madam Sujata Dalvi has not joined. So we will have words of Madam Sunita Tandurkar. Can we have her CV?
Yes.
Bhavna, can you just project her CV? Apart from the formal CVs, what I know, Dr. Sunita Tandurkar, she is, the giant in the field of gynec endoscopy. Definitely, I'm sure now majority of us have listened to her variety of talks, right from gynae to endoscopy and infertility, but her mastery in the field of endometriosis and the operative laparoscopy is definitely worth watching, listening to, and admiring. So Madam is all of you know now, she was the Vice President of FOXI, President of POGS in the recent past, and of course she's the head of department of the IVF and Endoscopy Center of Ruby Hall. She's the advisor and consultant for DY Patil and IVF and Endoscopy Center as well. She's the founder and medical director of Solo Clinic IVF, a center for excellence in infertility. And she has got the extraordinary achievement as India's first stem cell baby and world's first at the age of 45, that is on 16th April 2018. With this, I introduce Dr. Sunita Tandulwadkar, and we are eager to have your precious words, madam. Over to you for your words. Bhavna,
Thank you.
stop sharing.
Thank you so much. Thank you so much, Sneha, for your so kind word. Amongst Dr. Pardeshi, our president, he's rocking. He's completing now 2 years soon, but the amount of work he has done, and that's because he chosen right committee chairperson in a right subjects. All his committee chairperson, he has given so much freedom to work, and that's the quality of a leader. The way Sneha is working with her committee, massive work everyone is doing. Not only because they are going for an election, otherwise also, I know Sneha, very hardworking, sincere, honest, dedicated lady she is. And I wish her all the best. All your efforts will come, will give you fruits. Shamal, I congratulate you for becoming
Good
his
evening.
third
Good evening.
vice
Where are you in
president.
now? In which city are you in now?
I'm in Mumbai.
Okay, okay.
I'm in Mumbai. नवी मुंबई के साथ आज प्रोग्राम है. And then our Dr. Ajay Mane, another dynamic person. I think Ajay Mane has worked so much. It's like a shadow with Dr. Pardeshi sir. Both of them, see, when you have a good team, not only you do good work, but you enjoy doing good work. And that's what I see always with Pardeshi sir and Ajay Mane working together. Always, always. Most importantly is, Sneha, you have a knack of taking the people along with you. In your program, you have Dr. Suman Sinha, Dr. Supriya Jaiswal, and Dr. Indrani Roy as the conveners. I know Suman Sinha, very hardworking. Since yesterday, 3 times she called me and reminded me. Supriya is doing amazing committee work. I know how passionate she was and how badly she wanted this committee. And once she got that committee, she's doing amazing work. डॉक्टर इंद्रानी रॉय, आपको देख के ही लगता है कि आप बहुत सात्विक हो. बहुत सात्विकता से आप पेश आते हो. बहुत सात्विक है. And your choice of speakers, Arun Barua, very dear friend, Shamal himself, and you are moderating the panel. I think this will be, such a fantastic webinar for anyone. And the way we obstetrician are doing the webinar, I think even the government comes up that they have to take a CME or they have to give an exam every 3 yearly, 5 yearly. We will have 100% result with the OBGYN. Itna hum teaching karte hain. So it's lovely. Arindam, I see you and I admire you. Dr. Apurva Kumar Bhattacharya, thank you so much. It's lovely to see you all, Nilakshi. And also, my best wishes to all of you, those who are contesting, those who are not contesting in their personal life, in their professional life. I wish you all the success. And Dr. Pardeshi sir, you make us proud. We are so proud that we belong to AMOGS. It's such a vibrant society you all have made. See, Nandita has taken, you have, to join in or to enter in the footsteps of Nandita was a very difficult job. And the way you have done, Dr. Pardeshi sir, salute to you. Salute to you. You have done your own dynamism. And that's why AMOGS webinars are happening nationwide. They are not located only in Maharashtra. And that's the beauty of it. Thank you so much. And I wish you all the best for this webinar.
Thank you. Thank you so much, madam, for your wonderful words. And of course, always appreciating everyone.
Believe me, I'm feeling, now 1 mahina bhi nahi bacha hai. I've got so used to moving. Today I'm in Mumbai, tomorrow I'm in Raipur, then in Hyderabad. So now journey is ending, elections are coming. So I have to back to work, sit in Pune now. I'm enjoying this moving around.
Thank you so much, madam. With this, all of your blessings, I declare that the inauguration has been done for this program, and with God's blessing and the blessings of the seniors, we go ahead with the academic session. And I hand over this session now to Dr. Suman Sinha, Supriya, and Dr. Indrani for the academic session. Over to you, dear.
Thank you, Sneha madam. We had a very lovely and very interactive, I can say rather, the inaugural function, and we will wait for our other faculties who have not joined till yet. When they will come, then we'll take over their blessings. So with the start of the academic session, we are going to start with the first speaker, our luminary, Dr. Samuel Seth, sir, the Vice President-elect from our zone. Congratulations, sir. And for the chairpersons, we have Dr. Ajay Mane and Dr. Nilakshi Furkan. So can I have the CVs of, of the chairperson first? Yeah, chairpersons. Sorry, the speaker. Yeah. So it's a pleasure.
Sumanji, we'll save time. Skip that.
तो सर एक लाइन तो बोलने दीजिए.
नहीं.
It's okay. You don't read, say whatever you want.
All these CVs are being read on so many occasions. It's not.
सर एक मिनट मुझे.
You can stop sharing. Yes. Suman, please unmute yourself. I think please unmute.
I want to say only few words for Dr. Ajay Mane, sir. He was with me last year, whole year, and we enjoyed working together. And we have become so friendly, just like brothers and sisters. So, sir, welcome in this webinar, and I request you to do support me and yeah, madam, and Sunita madam for the coming elections. Look forward to see you again. So, sir is the chairperson of this session, and I want to introduce Dr. Nilakshi. Can I have Dr. Nilakshi here? Dr. Nilakshi CV, I want. Bhavna? Yeah. So can I take her CV, or we can start straight away, go to the Dr. Nilakshi. She is a very, very good friend of mine, and she is the president of Guwahati OB-GYN Society. She is a consultant in Pratiksha Hospital at Guwahati, and also the director of Gynec Center. She has done lots and lots of work in the upliftment of women's health. Welcome, Dr. Nilakshi, and kindly introduce our speaker, Dr. Samuel Seth, sir, and Dr. Ajay Mane, sir, will conclude his talk.
Good afternoon, everyone. It's really nice to be a part of this webinar, and I'm really fortunate to introduce my friend, Dr. Shamal Seth, who is the Vice President from Eastern Zone of FOGSI. So he doesn't need so much of introduction right now. He's a consultant practicing gynecologist from Kolkata. He works in Woodland.
No need to read all these things.
Well, you can start your talk. Start sharing.
Committee member of the conferences organized in Kolkata, and we all remember the AICOG of Kolkata, which was really a fantastic one. So I think the stage is yours, Dr. Shamal Seth, and we will hear from you the very new thing what is coming up with FCL. Thank you. Please start.
What happened?
Hello, Dr. Shamal.
I can't see Dr. Shamal here.
Shamal bhai left?
No.
He's not there.
He was there, but the network was poor, and I think he just disappeared.
Should I call you?
Yeah, just call Suman.
Really, when I was
Are you sharing? Are you sharing, sir? Are you sharing? No, this. 1 minute, sir. 1 minute. Dr. Shamal is telling that he is there only, and the whole screen is paused in front of him. So can I tell him to rejoin?
He will exit and then again.
Ask
once
him to
again-
rejoin. No, madam, Suman madam, ask him to rejoin.
जी.
Leave
Sir,
and rejoin again.
Log out and log in.
पर निकल लॉग आउट करके फिर लॉग इन कीजिए तो सर. हाँ.
He is not here on the panel. I can see that Dr. Shamal is not here on the panel.
Even Dr. Nilakshi is not here. He's telling that to
Nilakshi is here. I can see
Yeah.
very well. Nilakshi is here on the
Yeah.
panel.
And Nilakshi is here.
Yes, he is here. Yes. He is telling that the screen has paused in front of him.
No, he is not here.
No.
He has
Yeah,
to join.
No, by mistake, he must have left the webinar.
Yes.
Then ask him to rejoin again. उनको
Told
फिर से
him.
ज्वाइन करने के लिए बोलिए मैडम.
बोला है.
Yeah, ठीक.
For Dr. Nilakshi, she is here and she is unmute also. She just wrote that her network is poor. That is why she's not putting on her video. Okay. So whether he is joining again, how?
He told. I told him. He said, "Okay, I'm logging out and then I will rejoin."
Oh. I think Kolkata, there should be no problem for network, no? Indrani and Northeast Arunachal people, they have lots of problems for network issues. But
Yes.
Kolkata should not have actually.
क्या करें? How to help him?
What did he say?
He said that the whole screen is paused in front of me. I'm there sitting. I can't see you all. I said, no, sir, you are not in. So kindly log out and then again log in. He said, okay, I'm doing. He said.
Call Arun sir also by the time, because otherwise there should be no problem. Problem with his laptop, he's not, I mean, his screen got paused and even the cursor is not moving. So he's joining from different device.
Could you talk to him?
With Shamal? Yes.
Huh?
Yes. He problem with the device, he said. What to do now?
He will send his PPT and anybody can.
You share with me. I will share for him.
I'm telling him to send his PPT and he will talk from the mobile.
Let him join at least because काय करायचं अजय?
Hi, Dr. Suman.
Dr. Nilakshi.
Just check whether he is joining in the delegate link, maybe by mistake. Then we can't see him. He also
No. It's a problem with his device. His screen has paused. The cursor is not moving. That is what his problem was. So,
Okay.
yes, because I told him to.
He can log in from his mobile then. Sending
we can change.
Tell him to join from mobile. I will share his PPT. Just WhatsApp me. That is also okay for me.
I was going to tell that only, but he is not picking up the phone. That is the reason. Even the mobile is not working. Ring is not going. Available. हाँ तो सर ऐसा करें ना, आप पीपीटी भेजिए ना अपना, हम लोग यहाँ दिखाते हैं आप. अच्छा ठीक है गुड sir is joining.
Yeah, because Ajay has to travel, no? That is why we have to take other. And after this talk, we'll see what.
Sir, I'm joining.
सर क्या इंस्ट्रूमेंट का प्रॉब्लम है क्या, लैपटॉप का?
हाँ, लैपटॉप का प्रॉब्लम.
तो दूसरे इंस्ट्रूमेंट से ज्वाइन कर रहे हैं क्या सर?
शायद बोले कि मैं ज्वाइन कर रहा हूँ.
नहीं, स्नेहा मैडम जो बोल रहे थे ना, इधर से दिखा देते हैं, आप उधर से बात कीजिए, फोन से ज्वाइन कर लो बोलना.
मैंने बोला है बोले वेट आई एम कमिंग.
अच्छा ठीक. उधर यूट्यूब पे कितने लोग हैं? स्नेहा मैडम, यूट्यूब पे कितने ज्वाइन हुए?
यूट्यूब पे देखा नहीं मैंने एक्चुअली. ये she will update us. Bhavna.
Yes, ma'am. Let me check.
Yeah, आपल्या ह्या प्लॅटफॉर्मला असतातच कॉर कनेक्टच्या 500+ असतात.
Then what I will do, I will start one lecture which I have delivered in Nashik. It is there on my laptop at present. Shall I start till he comes?
ठीक है ना, no problem. But then once he joins.
हाँ, श्यामल भाई ज्वाइन होते तो मैं बंद कर दूंगा.
Okay, ठीक है ना, कर दो.
चलेगा?
Yes, why not अजय?
YouTube का कितने लोग हैं पूछो एक बार.
नाही करून टाक ना, काही प्रॉब्लेम नाही. तिकडे असतातच 500+ असतात तिकडे.
चलो ठीक है, मी करतो सुरू.
बहुत अच्छा है, 500+ तो वेरी गुड.
हाँ, every time she posts the screenshot, no?
कितने?
You can see the full screen needed.
कितना है?
फुल स्क्रीन कर दीजिए सर.
हाँ, वो कर लेता हूँ.
हाँ, ऐसे दिख रहा है.
Yeah, is it seen?
Yes.
Okay. Good evening. Till Shamal bhai joins, I'll continue with my lecture. It is medical legal issues in clinical practice. It is a day-to-day practice basically. Just I'm giving you the tips rather to waste time in waiting. He's trying. So these are the laws related with the doctors. There are 25 laws basically, and if you extend to partly laws, then it becomes 51. So all these laws, so only this Bombay Labor Welfare Fund, no, this one, Shop and Establishment Act, it is not applicable nowadays. It was previously, it was applicable to all of us, but now it is not applicable. Fine. Okay, these are the Indian Penal Code which are related to us. Section 202, intention, omission to give information. मतलब हम information कुछ देते नहीं हैं लोगों को, तो then we are liable for the punishment. Sorry, 269 is Negligent Act. Then 302 अपने को implement nahi hota hai. It is not applicable to all doctors. The Supreme Court has given a verdict that only 304A is applicable to the doctors. 302 is not applicable. Then and then only the case has stood, Dr. Sharma, Rajasthan case and everything. But nowadays, some mischievous things is being done by some authorities, but it is not true. Supreme Court has given clear-cut verdict that only 304A, death by negligence, is only applicable to all doctors. So don't be afraid. 301 to 306 is applicable for the unauthorized or whatever without women's consent. MTB is done. 319 to 322 is voluntary causing hurt. Then 499 is very good for us, defamation, but we don't dare to have this defamation case against any paper or any person who is harassing us. So we can do that. On a lighter note, what are the tips to avoid litigations in medical practice? Our safety first. How? There are only 5 options. Okay. First option, do not become doctor, which which we missed. Fine. The second option, though you become a doctor, don't practice. Go into plotting section, have a big hospital, appoint one advisor or administrator there, and become a rich person who will go to collect the money only. Okay. That is not possible. Then if you want to do practice, select some non-surgical lines. And if you want to do surgical lines, then become a medical gynecologist or a non-cutting surgeon. But mind it that here the ghost surgeon will come, operate, and will go. But the liability will lie on you because the surgeon's name will be yours. It is not the ghost surgeon's name. Fine? That is clear. Criminal liability do not get transferred. Only civil liabilities get transferred. So you are liable for the punishment. And for surgeons, do surgery, strictly follow the basic rules, guidelines, and the protocols and be free. If you don't follow the protocols, this will happen. Okay, this is on lighter note. Don't take it seriously. Now, this is serious. Patient can do anything. In Nashik graveyard, Ivan James, DYSP of police, beloved father of such and such, husband of such, died on 20th June 2001 due to the negligence of Sujata Birla Hospital and Dr. Chawla of Nashik Road. They have engraved on the graveyard. See, the patient can do what the patient can. Second thing, the sorry, the paper, the newspapers, and the whatever the persons there, what they have given, cervical cancer se bachne ke liye teekakaran zaruri, and they have given cervical spine, cervical cancer. Means they don't understand the gravity of the subject and they are giving the articles. Just now I have read one article in Lok Satta that, just a minute. Hello, ha sir.
Yes, so Shamal Bhai has joined.
How सांगतो मी lecture देतो. So Lok Satta, they have given that missed abortion. The heart sound is not heard. So we call the patient after 7 days. Again, try to see the cardiac activity. If it is not there, it is labeled as missed abortion. And that Patrakar, he has given in Lok Satta that this is the business of doctors, and now they are aborting the fetus under the claim of that missed abortion and whatnot. Means they don't have knowledge, but they do this. Are you a victim of medical negligence? This is very serious. It has come from Europe. The advocates are asking, are you suffering? Then give us. No win, no fees basis. What is that? If you win, then and then only the fees is paid to the lawyer. Or if you lose, then the lawyer is getting 0 rupees. And the lawyers are ready. So this is very serious part on the hospital part. So this is mob violence. I see that. Yeah. See, in ICU, they change and go everywhere. And in ICU, what they are doing. See the behavior. They are beating the doctor. They are beating the staff. Everything is disturbed. So this is a in presence of police. And this is government doctor. They are doing it in the presence of police in the government hospital. Sorry. So this is a serious issue. Misinterpretation by the patient. This is on lighter note. मैं और मेरी तन्हाई अक्सर ये बातें करते हैं. And what she will say, what I say that shall we go to a psychiatrist because he is speaking alone. So she is misinterpreting that. This happens with the patients. So I have put some situations to understand the conditions. Patient came with a pregnancy of 17 weeks for first time and her age is 17 years. What next? What next? The patient is 17 years. Any patient coming to you below 18 years completed is a minor patient. And if she is pregnant, though married, though unmarried, you need to inform the police, nearby police station or the child welfare committee in written format. And this is mandatory for you under POCSO. It is a Protection of Child from Sexual Offences Act 2012. Okay. If you do not inform the police, you are liable for the 6 months imprisonment. Fine. So POCSO applies here. So patient is 17 years. The weeks does not matter. If she is 18 years and it is 32 weeks, then again we need to inform the police. Why? Because when she conceived, she was not major. So that again comes under POCSO. Follow protocols and documentation. What documentation? Give the information to the police. It is not FIR. It is just information, first-hand information. Information to police and get a receipt from them. Because afterwards they may say that you have not informed and you are liable for the 6 months. This next situation. Same 17-year patient registered with you in OPD register and came to you. But as you tell her and the relatives about the POCSO Act, they ran up. What next? Patient comes. And many times it had happened that patient ran away. Because listening to the police name, they run away. Then also you need to inform because your register is having the address and the name of the patient. Put it in the letter and inform to the police. Fine. Okay. Next situation. Patient of 18 years completed 1 month back, came with a pregnancy of 20 weeks. See, just now I told you, to be or not to be. Batana hai, nahi batana. Kya kare? Patient 18 years completed 1 month back and pregnancy of 20 weeks means 5 months back. So when she conceived, she was not 18 years completed. So again, POCSO Act inform the police. Next situation. Patient not giving ID proof and birth date proof. You need that. By law, it is not mandatory, but you need that because some of the patients, they say her age is 19 years and 20 years and afterwards, some document is published or document is given to another hospital or somewhere and it is proved that the patient is of 17 years or 16 years. Then you are in trouble. So take a valid ID proof, either Aadhaar card or voter ID card or a PAN card. PAN card, I think date of birth is not written mostly. The passport is acceptable, but the ration card is not acceptable. Okay, there you don't have the photographs. The photo identity is very important. And this patient is not giving ID proof and insisting for the abortion. Then shall you accept the patient? No, you shall not. You shall deny the patient. It is a right of a doctor to deny the patient or refuse the patient to treat unless and until it is a life-threatening condition. Patient की जान जाने की नौबत आ गई है, एक्सीडेंट का पेशेंट है, ब्लीडिंग हो रही है, या इनकम्प्लीट एबॉर्शन में आया, दो ब्लीडिंग हो रहा है, she is pulseless, she is bleeding. That moment you cannot refuse the patient, but in this situation you can refuse the patient and don't treat the patient. Patient came in bleeding and infection. She had attended a quack or taken MTP pill through quack. How can we proceed? She has taken MTP pill by the quack means it is a illegal abortion. Then you need to inform the police, do a MLC, inform the police, and after police comes, do the Panchanama, take the statement of the patient, then proceed for the further. Okay, next situation. Police calls you and demands case paper of MTP you performed 2 years back. As girl filed the case against that boy as a rape case. Because before 2 years, they were in goody-goody relations and they had sexual activity with consent of both parties. And now he has refused or something has happened. We don't know that. We are not judged, but you have performed MTP. You have performed MTP. Why? Because it was illegal. She was major, and that time you performed the MTP. So if police demands the paper, are we liable to give the papers? Yes, because the police can ask for the papers. We need to arrange the paper in a complete chronological order. Put the number of the paper on right upper border, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, whatever, 10 papers, and give them Xerox copy. Don't give them original papers. Original paper must be kept with you and you only. The police insists, give me the original paper. You say, no, we are not going to give you original paper in any condition. Okay, give them photocopy and take a receipt from them that they have received 10 pages paper Xerox copy with the reports. Then, okay, they may take your statement and go. So you are not liable for any punishment. Fine. Next situation. Patient came for USG for pain in your abdomen. Patient is 16 years, married and found pregnant of 8 weeks. What next? Whosoever come to know that the patient is pregnant and she is below 18 years, that person must inform the police. So here, sonologist must inform, and sonologist send the patient to us, then we should inform. So the same condition here. An NGO or Mahila Ayog coming for inspection, can we show documentation? No. Only authorized persons, those are civil surgeon or chief medical officer of corporation, or the persons who has been given authority to see the papers by these two persons. They are only allowed to see the paper. Patient is psychologically disturbed, or she is under the treatment of psychiatrist. Then a letter from psychiatrist of her treatment must be taken and consent from the guardian or warden, and then only the MTP is done. Fine. Next situation. Unregistered patient came in early labor. Unregistered. So she has not booked with you. She is coming in emergency, so sorry, and not ready for any investigations, and ask for the admission and delivery. Can we deny? Yes. Why? Because she is in early labor. We can deny. We can send the patient to other centers. Say you are not registered with us, so we are not liable to take you in any condition. Send with the proper documentation, with a referral letter, and put a copy of referral letter with you. Okay. Now situation is different. Registered patient with routine follow-up came at full term in labor, not in pre-labor, and insisting for normal delivery only, and not ready for CS if needed, as fetal heart rate is fluctuating. What next? In this situation, we must have faced, everybody is facing this situation. Patient is insisting, नहीं जहां तक हो सके आप है ना normally करो, सीजर मत करो इसका, और आपके पास ही करो, हम लेके नहीं जाएंगे, ये full labor pains में है, आप क्या करेंगे उसका? हम लोगों को मालूम है कि CPD है या something is there, because she is registered patient. No, we know everything because we have called her for the elective cesarean section and she has not come. The Satara case is same. The doctor has called the patient has not come for the routine follow-up or the given date for the cesarean section, and she came with the baby out and the head inside. And the Zeughaus manner is done, the baby is pushed inside, then delivered by the cesarean section, patient, the fetus expired, patient is alive, the mother is alive. But though they have filed the case against the doctor, and the doctor is put the charges of criminal charges. So it is very difficult situation we are at. In such situation, if the patient is registered and this is the situation, then record proper findings. On admission, the findings must be recorded properly. That will save you in the court of law if something goes wrong. Okay, patient is insisting for normal delivery. If something goes wrong, you need to have that. So partogram is very important. We don't have a practice of having partogram in private practice. It is very wrong. You have a partogram in each and every government medical college. We were used to have partogram. Now WHO has given a partogram because partogram is a legal document. We can prove that this was the situation, this was the point where we have advised cesarean section and patient was not ready. So we are free. So fetal record, CTG, negative consent. What is negative consent? Patient is not ready for cesarean section. Take a consent for that. Take a left thumb impression along with the sign and wait for the seizure. Patient not progressing well in labor, not ready for CS, and not ready to shift to another hospital also. What steps? Same thing. All record is been put on the paper. patient come with a hand prolapse, counsel about the consequences and document it, signature of the witness, consent of the procedure, because cesarean section is to be done, and then cesarean anesthesia consent is different. It is different. We must take two consents, one for procedure, one for anesthesia. Anesthesia consent is must, and must. Anesthesia notes are also must. We have seen the papers where the anesthetist do not put a single letter on the paper and goes off. Fine. Sneha, madam, if
Yeah.
Shamal bhai comes.
Shamal has already joined when you started, but we.
Oh, I'm so sorry. I'm sorry. I'll wind up. Thank you. Thank you very much.
Don't say. It
No.
was very interesting. And
No,
in fact, thank you so much for the informative talk, Ajay.
Yes.
Ajay is my younger brother, and we are, working together in MOGS as well as Foxy.
One more thing, I just wanted to please help my sister to go to Foxy. She is a very hard-working person. So these are two sisters, Sneha Tai and Suman Tai. दोनों को आपको मदद करनी है और इस बार Foxy भेजना है. So please vote for them. Thank you very much.
Thank you.
Shamal bhai,
Thank you so much.
Yes, sorry for the technical problems, but
I
want to disagree with you on 2 points. One is after 2 years of MTP, if the police asks for the papers, I am not supposed to submit the papers to the police.
No, sir.
I
MTP
will only
kept
give
for
it
5 years.
Only. Now, if you have done the MTP maintaining all the protocols, your original paper is already sent to the CMOH. It's not with you.
No. Papers are kept with us only.
MTP records, if you say
MTP record, you are talking about PCP edit. PCP edit is 2 years.
Supposed to all those things to CMOH.
No, sir. MTP record is kept with doctor only with the sealed envelope.
Not the origin. No. You need to send all these things, consent forms, opinion forms, admission record to the CMOH, no?
No, sir, no. It is
Ajay,
to be kept with, no, sir,
no,
it is
Ajay,
to be kept.
No, Ajay, I beg to disagree. All the records of MTP you need to send to the CMOH before the 5th of the next month, including the consent form, form 1, the opinion form, the admission register, all these things. You need to send to the CMOH.
Sir, it is a form 2. Sir, it is a form 2 where you give the summary of the MTP. And it is to be given to CMO. The original papers are to be kept with the consultant or the owner of the hospital. It is not to be sent to the CMO.
If it is a medical methods of termination, then
no, sir. All methods. It is a mandatory to keep in a sealed envelope with the administrator or the owner of the hospital.
No.
I'm sure.
I think you need to check with this.
No. I will send you the law, sir.
No, Ajay. I'll just beg to disagree anyway. It's another point is that patient not showing age proof. It can happen, and always we do not ask for the age proof from our patients. Now the MTP Act says you ask the patient to write her name, address on the consent form in her own handwriting and ask her or allow her to mention her age on that. But you cannot deny that. You should not. I won't say you cannot. You should not deny. And if you are genuinely sure this is a 13-year-old girl, how can she write 19? That's a different thing.
Yeah.
But sometimes it happens. It's very difficult to understand if a girl of having polycystic ovary features of PCO, it's very difficult to judge the age.
Correct, sir. Yeah.
So it's not always mandatory that you need to check the age. MTP Act says it's not your headache to check the age proof.
Yeah. By law, it is. I told already. By law, it is not mandatory. But for our safety, it is additional precaution we should take.
But in that case, it's better that you go ahead with the procedure, preserve the products of conception for future analysis.
Just to lose 5,000 rupees is good rather than to have a headache of 5 lakh rupees afterwards.
Then one should not do MTP. if you consider the issue of confidentiality, basically 99% of us are not maintaining the confidentiality. It should have been done as the law wants.
Correct.
And thank God people are not aware. Otherwise, most of us would have been in custody by this time. Anyway, I'll switch to my. Should I share?
Yeah. Yes, sir. Start, please.
Thank you, Ajay, for making time for me. So I'll be speaking on IUGR and management. So good evening, everybody. Thanks to all of you for waiting because for the technical problem, I had to I had to go off totally, and again I rejoined. I entered the mail and everything I had to do again, and now I am okay. I am supposed to go ahead. Thank you very much, Dr. Suman, Dr. Sneha, and Supriya, for inviting me to deliver something, to share some of my knowledge on this important topic. And very frequently, we all practicing obstetrics come across this scenario: intrauterine growth restriction or growth retardation or fetal growth restriction, whichever way we can designate this topic. And the most important thing is, how can we recover ourselves? I won't say to recover the patient. This is a very important task for recovering ourselves from the crisis, to take the patient to such a situation when you are safe enough to deliver the baby with a handsome, good body weight, in a good outcome of the good perinatal outcome. So keeping all these things in mind, I am going ahead with this IUGR and management. So these are the terms we use: IUGR, SGA, small for gestation age, fetal growth restriction is the most modern term which we have been using now. Now, definition: it occurs when the unborn baby is below the 10th weight percentile or his or her age in weeks. The fetus is affected by a pathologic restriction in its ability to grow. A low birth weight, it's not always synonymous or with the term of fetal growth restriction. Means a baby with a birth weight of less than 2,500 grams, which could be due to IUGR or maybe prematurity. So there is a little line of difference between the two terms: growth retarded fetus and low birth weight baby. Now, if we want to classify it, although on many occasions we cannot, but on few occasions when the outcome is already evident, we can to some extent classify as a normal small fetuses, abnormal small fetuses, or growth restricted fetuses. Now let us have an idea about all these three terms. Normal small fetuses basically do not have any structural abnormality. They are having normal umbilical artery and normal liquor, but body weight is less. They are not at risk and do not need, in most of the cases, any special care for them. Abnormal small fetuses have usually chromosomal abnormalities or some kind of structural deformities. They are lost cases and they deserve termination, as nothing can be done in most of them. Coming to the most important thing, what we are supposed or concerned today is growth restricted fetuses due to impaired placental function of different causes. It can happen because of innumerable causes, and sometimes we do not understand why it's happening. Appropriate and timely treatment or termination of the pregnancy can improve the prospects of the baby. So coming to etiology, yes, this is very difficult to put the etiology on the screen, but in your practice, it's not always evident what is the kind of situation which is promoting the baby to be restricted in growth up to that percentage. So it may be dependent on different factors. I have already mentioned several factors, resulting in small for gestational age babies, which can result from many factors which are known and several unknown factors, either acting singly or maybe in conjunction with several etiologies in association with the one another. The etiologic determinants have two measures of effect on the baby. One is relative risk and the etiologic fraction. Most of the evidence of etiologic determinants is based on observational studies. We all know this is basically observational studies, and systemic overviews or meta-analysis of such studies. I will mention some of these studies later on. There are several studies which are coming out with the evidence that what kind of steps we should take to overcome this crisis, at least to some respectable limit. We cannot always treat and give the patients having a baby with a normal birth weight otherwise, but at least to some respectable birth weight with a good outcome, and in some cases when there is gross oligohydramnios, so that at least there is marginal increase in the volume of the liquor. Now, in a majority of cases, say around 40%, the cause is unknown. I have already mentioned, sometimes on many occasions, we are not aware of the causes of the etiology which is predisposing to this situation. They are probably due to placental insufficiency of whatever causes. Whatever may be the cause, it's basically placental insufficiency which will predispose to growth restriction. So coming to all these causes, general causes, maternal causes, fetal causes, placental causes, and most important is idiopathic. We all know what the idiopathic means. Courtesy Professor P.C. Mohapatra, when we are considered as an idiot and patient's condition become pathetic, that is called an idiopathic condition. And medical science is in unexpectedness, is in a state of, you know what is going to happen. That's because of this, all these idiopathic causes, and the causes behind fetal growth restriction is no exception, that you cannot treat until and unless you are aware of the etiology of the condition. Now coming to maternal risk factors, I will not be going into the details because we all know what are the maternal conditions, starting from a high risk pregnancy like who had had an IUGR baby previously, extremes of age, mother herself is of very small size, height and weight, has got very poor weight gain and malnutrition during pregnancy, socially deprived, uses substances like tobacco, narcotics, alcohol, which can cause abnormal development or birth defects, and has a low total blood volume during pregnancy of different etiology. So all these maternal factors may contribute to a baby who is going to have a restriction in its growth. There are other factors. If a pregnant lady is having one or is more than one baby, then each of the babies is going to be of low birth weight. Patients staying at high altitude. Patients having a drug therapy like anticoagulants and anticonvulsants, they are having a tendency to have a low birth weight babies. Having a cardiovascular diseases like preeclampsia, hypertension, cyanotic heart disease, cardiac disease of grade 3 and grade 4 with a gross restriction of activities, and diabetic vascular lesions. All these can contribute to a baby which is found to be growth restricted. Chronic kidney disease is another important etiology. Chronic infection, whatever kind of chronic infection, can cause growth restricted fetus, and in few cases as an antibody problem that can make successful pregnancy difficult, like antiphospholipid antibody syndrome or SLE. Now, if you consider the fetal risk factors, exposure to an infection like German measles, cytomegalovirus, herpes simplex, tuberculosis, syphilis or toxoplasmosis, tuberculosis itself in general, malaria, parvovirus, B19 infection. So all these causes, if the baby is exposed to all these kind of infections, then baby may be having a growth restriction during the pregnancy. A birth defect, we all know birth defect can cause restriction of the growth. A chromosome defect of any kind, it's going to, except in few cases where the baby is tend to be plethoric. In other cases, a chromosomal defect will ultimately lead to a growth restricted fetus. A primary disorder of bone or cartilage, a chronic lack of oxygen during development. We all know hypoxia is a factor, chronic hypoxia for poor development of the growth. Development outside the uterus, and placenta or umbilical cord defects, because placenta and umbilical cords, they are the main systems which help the baby to grow in its satisfactory way, because they are the main things which supply the nutrients and the circulation from mother and interconnect with the baby. Coming to placental factors, uteroplacental insufficiency resulting from anything. I will not be going into the details of what are the causes of uteroplacental insufficiency. We all are aware which can cause, and fetoplacental insufficiency, that also can cause growth restriction of the baby itself because of vascular anomalies of the placenta and cord, or maybe decreased placental functioning mass, like say, small placenta, like in conditions of abruptio placentae, placenta previa, or post-term pregnancy when already there is hypofunctioning of the placenta has started. So in all those cases, baby growth may be restricted. Now, diagnosis is very important. And clinical diagnosis is the hallmark of all these cases, because only when you can clinically think of, then you are going to correlate your diagnosis with the other parameters or the other parameters for the confirmation of the diagnosis. Otherwise, if you are not clinically sound, then it's very difficult to diagnose. Now many of us do routine sonography in each and every visit. Now, in those cases also, this is more easy to diagnose much earlier, or maybe in certain cases you can over-diagnose that possibly the baby is going to be growth restricted. Now, presence of risk factors, inadequate growth detected by serial measurements of weight, abdominal girth, and fundal height. All those are clinical findings. Ultrasound, still the hallmark for the diagnosis of growth restricted fetus. Whatever kind of inadequate growth, reduced AFI, placental circulatory problem, or maybe in some cases premature calcification of placenta, that can also lead to growth restricted fetus. So coming to neonatal diagnosis, forget about this, because that we are going to diagnose only after the delivery of the baby. And I hope, I believe, before the baby is delivered, we can diagnose an IUGR baby. So normal and IUGR newborn babies are shown over here. You can jolly well differentiate how is the difference between the size of the babies and the sizes of the placenta. It's just absolutely very simple to identify. Now, can you prevent really? Not always we can, but if we can diagnose early, especially the etiology we need to diagnose, then actual and proper treatment and the patients adhere to the treatment, then in some cases you can recover, and the growth and the volume, Leica volume, they do improve as the pregnancy approaches towards term. So strategies include prenatal care modalities, protein energy supplementation, treatment of anemia if it is, vitamin and mineral supplementation. Now, what is the fact is that almost all of us during our antenatal care prescribe some kind of all these things, but still we come across the cases of fetal growth restriction. Now, recommendation of fish oil supplementation and prevention or treatment of all these things. If she's been suffering from hypertension, then you need to treat and prevent. If the baby is having a compromise due to other factors, you need to treat that. If it is an infective cause, you need to eradicate that treatment, that infection with adequate and proper treatment. But you need to diagnose first is what kind of infection it is. That yes, she is having hypertension. She is having some kind of problem which can cause to placental insufficiency. Until and unless you can find out something, it's very difficult to treat in most of the cases with just the strategies I have mentioned on the left side. So strong evidence of benefit only of the following interventions. Not always we are of the benefit of all the strategies we do actually in our practice, because we need to. Whenever we come across, or we say at least a 20% difference in the approximate growth of the fetus, which should be at that particular gestation age, and whatever we can find at that particular age clinically, we need to mark it, yes, small for gestational age. And we start our special care from that period only. And we need to counsel the patient. We need to inform the patient, yes, you have got a tendency that your baby is going to be growth restricted. And there are several other advices, adequate rest, adequate sleep, restriction of other activities. We need to give advice. So balanced protein and energy supplementation, strategies to reduce maternal smoking. Very few of our mothers actually do smoke. Antibiotic administration, if you can diagnose a kind of infections, whatever it is, maybe UTI, maybe RTI, whatever. Anti-malarial prophylaxis, if at all, although incidence of malaria have gone down a lot. These days, we very rarely can find a patient suffering from malaria, at least during pregnancy. And few statistically significant reductions in the risk of IUGR have been demonstrated with other interventions. So unless she is near term or prone to deliver, once treatment begins, the fetus must go surveillance. You need to monitor whether your treatment is achieving some kind of goal what you want to have. The purpose is to identify further progression of the disease process that would jeopardize the fetus to a point that it would be better to be delivered than to remain in utero. So that's the point of your judication, that you need to be very judicious at a particular time when it can be of risk to continue the pregnancy for further. Vis-a-vis, you need to take the decision whether at that particular stage you are sufficient enough, your center is equipped enough to take out the baby and give a improved salvage rate of the baby at that particular duration or at particular birth weight. So there are 4 testing modalities by which you can monitor the surveillance. One is non-stress test, amniotic fluid index, Doppler of umbilical artery and the biophysical profile. And each of these addresses different aspects of surveillance. Not everything will point out to a particular kind of growth restriction caused by a single cause. But taking in together, you need to do the surveillance very frequently than what you usually do in other normal cases. And it should be aware to everybody that combination of tests are better than an isolated test. So one single test is not sufficient to identify, because if a baby is having growth restriction with a normal LICR, you need to think something different. If one is having a normal growth but grossly reduced LICR, cause may be something different. So combination of all these things, non-stress test, amniotic fluid index, Doppler of umbilical artery, and the fetal biophysical profile. You need to do this test in different combinations to mark out how much growth restricted the baby is or how much the baby is at risk in utero. I will not be going into the details of non-stress test. Coming to AFI, we all know what is the cut mark of the AFI, when you should be very careful. So I will not be going into the details. Now, the current recommendations are that if AFI decreases below 8 after 35 weeks, I think this is not to be acceptable at that moment. What we do, that if the AFI goes below 4, that indicates that yet delivery should be done as early as possible. If it is below 6, then you should be very careful and just start planning when you can deliver the baby. And if it is below 6 and 18, that is the period when we need to increase the frequency of your surveillance tests, whichever way you prefer to, maybe AFI, maybe biophysical profile, maybe doing a color Doppler study to have the whether Doppler studies are doing normal or not, any kind of placental insufficiency or not. So if it goes below 4, deliver. If it is between 4 and 6, be very careful and plan for the time of delivery. Between 6 and 8, increase the frequency of surveillance, whether it is going below 6 or not. Now, Doppler of the umbilical artery. When IUGR is diagnosed, the value of sequential studies of the umbilical artery Doppler waveform is to determine the resistance index is increasing or not. Now, if it is increasing, it signifies a deteriorating condition. We all know that. And the sonologist usually report accordingly. Coming to uterine artery Dopplers. Now, the R of limited use, uterine artery Dopplers, in several cases, when the baby is premature, below 30 weeks, it may not be of very use. When the pregnancy is prolonged, say beyond 40 weeks, makes no sense doing uterine artery Doppler. And it is a low risk pregnancy. When you are not dealing with a pregnancy which is so high risk, then uterine artery Dopplers may be of not that importance in ascertaining whether the baby is going to be that growth restricted, which may give rise to a concern in the mind of the obstetrician. Because 5% will be high but normal, but they are of very use in high risk pregnancies. You know, high risk pregnancy we are going to monitor in some different ways. Always, any kind of pregnancy which is considered as high risk pregnancy, of course, we need to have our parameters. We need to have our threshold much less than what we consider in other so-called normal pregnancies, and may be used to prolong pregnancy with immature fetus and apparent intrauterine growth retardation. So in sometimes when the fetus is mature, it's immature, whatever kind of, maybe it's a wrong date, or maybe you are dealing with a gestation which is not the proper at that particular period, it can be diagnosed as apparently intrauterine growth restriction but of not that concern if the other parameters remain normal. So these are having a very high negative predictive value for fetal death. So in those cases, we should not jump to a certain decision that this baby needs delivery. No, you need to be that much careful. So other pregnancy Doppler studies, fetal middle cerebral artery. I will not be going into the details. We all know which indicates what and how much they are important. The most important thing when we are of importance is when the reversal of diastolic flow takes place. And that is the point. Basically, you should not allow the end diastolic flow to go in the reverse way. And whenever there is a problem to that limit, that is the cutoff time that yes, you should deliver the baby then and then. You should not wait for giving us a steroid and wait for 24 hours or 48 hours. No, if there is reverse, then reversal, this is the point that yes, you should take out the baby. Coming to biophysical profile, we all know what is the scoring system. We all know which score is very safe, and when the score reaches to what, you need to take the steps. So this is not to be discussed basically, because these days we do not recommend biophysical score that frequently, even in growth restricted fetuses. Rather, we want to see this umbilical artery Doppler and the whether there is high resistance index or not, or whether there is on colored Doppler, there is any evidence of placental insufficiency or not, or fetal hypoxia or not, like our volume. So all these things taken together have given the value so much that biophysical profile to some extent has lost its importance in past few years because of the improved technology used in the sonography and color Doppler studies. So all these are parameters which are assessed during biophysical profile. Amniotic fluid volume is already in the surveillance. Whether its volume is AFI is going below 8, then at that point you need to be careful. Now non-stress CTG, looking at fetal heart short-term variability and accelerations. Now CTG is always recommended, but how long you should continue the CTG in every sitting, and how frequently you monitor with CTG. That is the question. Now assigns a score of 0, 1, 2 to each of these 5 measures as with Apgar score. So if we consider Apgar score after the delivery of the baby, which gives how the baby is born at the particular stage, if you assign a score of 0, 1, 2 to all these 5 things, is fetal breathing, fetal movements, fetal tone, amniotic fluid volume, and looking at the fetal heart rate variability and accelerations, those will give you a good guideline to take the decision or to come to a conclusion, yes, that the baby is having a mild form, a moderate form, or a severe form of growth restriction. So coming to 2 things. One is accurate diagnosis, and you need to keep in your mind whether the baby is salvageable or not at that particular period, whether the mother is at risk as well. So if it is that the mother is at risk because of that etiology, and whether the baby is salvageable, if you take the decision that yes, this is the stage we need to take the baby, accordingly you need to counsel with your patients. Ajay was saying what kind of medical legal things we need to be very careful. So if you take the decision, if you think that your center is not adequately equipped to deal with these kind of babies, better to shift the patient with the baby in utero, transfer to a tertiary care center where they can improve, they can have an improved salvage rate of all these babies. Now, the few things we advise our patients to stop smoking, having bed rest, to correct anemia. In most of the cases, ultimately, they do not contribute to much in improving the growth rate, in improving the volume of the liver. But monitoring of the fetal growth will continue, and timely delivery will give you or will make you a perfect obstetrician if you are judicious in taking out the baby. It's not too early, it is not too late. That's a very difficult point. It's not always possible for us, we are human beings as well, to choose that time that yes, this is the perfect point, we need to take out the baby. Very easy to say, very difficult to execute. Now, what are the treatments available? We all know what kind of treatments we give. This is the algorithm we all do, but most of the cases ultimately come out to be unknown. Why are we so much of concern to these IUGR babies? They are very prone to asphyxia. Yes, it is true. There are increased incidences of perinatal hypoxia, maybe chronic, maybe acute, increased cesarean section rate, decreased Apgar score, and increased resuscitation required in all of these babies, with a few exceptions only. They are at risk for hypothermia, hypoglycemia, hypocalcemia as well. So all these things you need to keep your mind, although you will have your pediatrician with you, but keeping all these things in your mind, you need to have your arrangements like that. So evaluation and management, your job is not over delivering the baby. Now job will be transferred to the pediatrician, but that will carry on your goodwill as well, with the kind of treatment, with the period of gestation that you have taken out the baby. That will give rise to whether the baby is having its growth and weight gain, growth of the head in the postnatal period. It all depends upon whether the etiology that was responsible for the growth restriction and at which point you took out the baby. All these factors will contribute to post-delivery growth of the baby. Now, coming to treatment, I will not be going into the details. I will come to the point of treatment which I want to. So all these things we all know from our student days, starting from aspirins, bed rest, good nutrition, good sleep, increased fluid intake, all those things. But the newer management strategies, although this is not a new now, this is in practice for last few years. Phosphodiesterase 5 inhibition, the newer approach in IUGR and oligohydramnios. Now, recent articles reveals that this is abundantly expressed in human placental IUGR model. So this is the thing we are going to discuss, and this is the latest concept as of now, which is available for the treatment of intrauterine growth restriction. PDE5 activities. So when there is abundance of PDE5 or increase in PDE5, there will be increased activity of the cyclic GMP levels, increased availability of the nitric oxide. There will be improvement in the placental vasculature in the form of vasodilatation, increase in the uterine blood flow. Accordingly, fetal blood flow will increase, and there will be increase in AFI. So IUGR and oligohydramnios are going to be improved. In the other cases, what is the pathology? So when there is increased phosphodiesterase 5, there is diminution of cyclic GMP, diminution of availability of nitric oxide, initiation of vasoconstriction of the entire uterine and placental vasculature, reduced uterine blood flow, reduced fetal blood flow, and reduced AFI. That causes the fetal compromise. And when we prescribe PDE5 inhibitor, that is going to reverse the situation. That's the action which is going to be expected by a product which is PDE5 inhibitor. That will help in improving cyclic GMP, improved availability of nitric oxide, that will cause vasodilatation, increased uterine blood flow and fetal blood flow, and increased AFI, and reversal of the situation of IUGR and oligohydramnios. Now, the only PDE5 inhibitor studied in pregnancy is the sildenafil citrate. We all are aware of this molecule. These are in practice for last several years. They cause decreased arterial pressure and improved arterial perfusion in human placenta. The sildenafil citrate, in the form of inhibition of PDE5, decreased arterial pressure and improved arterial perfusion in human placenta. There are several studies of sildenafil citrate in pregnancy, and all have proven that there is an improvement in oligohydramnios and the growth of the baby. The main benefit to pregnant women is an increase in fetal birth weight. That is the main objective, that it should be of a respectable birth weight, which is otherwise not going to happen if we consider the growth status at that particular gestation period. So there is no severe adverse maternal side effect by the use of this drug, sildenafil citrate, in pregnancy. That is the most encouraging point for all of us. So even if you are not sure whether which kind of growth restriction is there, mild form or not at all, still if you prescribe this drug, there is no incidence of side effects which are going to be found in the mother or in baby. So all studies show that sildenafil citrate significantly reduced vasoconstriction and significantly improved the circulation of fetal growth restricted small arterioles. So we can conclude there that sildenafil citrate will improve the endothelial function of the myometrial vasculature from women whose pregnancies are complicated by intrauterine growth restriction. And the most important thing is that it does not have any adverse side effect on the mother. So there will be lower incidence of neonatal intensive care unit admissions required after the delivery if the pregnancy has been treated, or maybe IUGR is rectified with the prescription of sildenafil citrate. Studies suggest it is safe in pregnancy. There is no teratogenic sequelae whatsoever have been found to any of the babies. There are several studies. There are a few Indian studies as well, and all of them are of the opinion that yes, this is effective in management of fetal growth restriction, shows improvement in color Doppler indices, and increases mean fetal birth weight. Apgar scores improved along with lesser NICU admission rates in sildenafil treated group than the placebo ones. So there are several other control trials. Sildenafil citrate 25 milligram thrice daily plus hydration, and the other group hydration alone with whatever kind of isotonic solution or fluid. And AFI was measured, and it was found that sildenafil citrate increased the amniotic fluid volume in pregnancies complicated with oligohydramnios in comparison to the placebo group. So only hydration is not going to work, but if you added it with sildenafil citrate, it definitely is going to give some improvement in the volume of the liquor and growth of the fetus. So it acts by its vasodilator effect, which can improve uteroplacental flow in pregnancies complicated by fetal growth restriction. That is the basic mode of work or function of the molecule. There are several other published clinical evidences for more than 300 subjects all over the globe, and no safety issues have been a word of caution from nowhere. There is no safety issues which could restrict anybody to prescribe this drug whenever one is coming or treating or dealing with a case of intrauterine growth restriction. So no safety issues in our country also. There are several studies done by our own colleagues. There is no fetal or maternal deaths or any kind of safety concerns found. There are several other studies giving significantly satisfying results. Sildenafil citrate 3 times a day till delivery. USG color Doppler was repeated after 15 days, and they are giving encouraging results. So the conclusion was for each study that it may offer a potential therapeutic strategy to improve outcomes in pregnant women facing fetal growth restriction and oligohydramnios. So coming to the highlighting of the treatment, judge optimum time of delivery, because that is dependent upon you. Other functions are being covered by the drugs, some kind of molecule, some kind of advices. But finally, it's you who need to decide the time of delivery. And you need to compare the risk of prematurity and difficult extrauterine existence vis-a-vis risk of intrauterine fetal death, or a meconium aspiration syndrome, or a hostile intrauterine environment for the baby if you choose to continue the pregnancy. Now we know what are the risks for IUGR: short-term intrauterine or interpartum death, late deceleration, severe variable deceleration, bit-to-bit variability, episodes of bradycardia. Intrapartum fetal acidosis may occur in as many as 40% of these cases, leading to a high incidence of cesarean. They are at risk of death because of neonatal complications like asphyxia, acidosis, meconium aspiration syndrome, hypoglycemia, hypothermia, SIDS. Anything can happen to these babies. and they are likely to be susceptible to infections because of impaired immunity. Now, coming to long term, they can suffer from IUGR at risk for death, low blood sugar, low body temperature, all these things we have discussed. They're high, these risks increase with the severity of growth restriction. So the more the baby is growth restricted, it's more severe, the more possibility of these things in the later part of the life. The growth that occurs after birth cannot be predicted with certainty based on the size of the baby when it was born. So you cannot check whether the postnatal growth is optimum and the baby growth was so growth restricted, but still they can have some long-term poor prognosis or poor development miles in their future lives. Infants with asymmetric IUGR are more likely to catch up in growth after birth than are infants who suffer from prolonged symmetrical IUGR. And if IUGR is related to a disease or genetic defect, the future of the baby is related to that particular severity or that particular nature or genetic nature of the disorder. Those will be interrelated. They are more likely to remain small for those of the normal birth weight. They will need special attention of primary health, nutrition, social services. They can be lifelong, affecting the body size, composition, physical performance. Sometimes, and with not many exceptions, they are immunocompetent. There may be less immunocompetent these babies are going to be. It appears to predispose to adult onset degenerative diseases like maturity onset diabetes or cardiovascular diseases. Each case is unique, cannot reliably predict an infant's future progress. So when we are dealing with a case of growth restricted fetus, we need to keep all these things in your mind, because we know we are going through medical legal era. Your job is not over by giving out a baby and patient going home safely or in a jubilant mood at the particular moment. You are still susceptible till the growth of the baby in future, or its developmental milestones are not optimum or near optimum. Otherwise, you may face some medical legal problem, even if the baby has, say, passed after 5 years, 10 years, 15 years, whatever it is. So take home message: PDE5 inhibition is a novel pathway for improvement of placental circulation and improving uterine as well as fetal blood flow. Is the only PDE5 inhibitor sildenafil cited is with efficacy in intrauterine growth restriction cases. Safety and efficacy have been proved in a number of preclinical studies. There are extensive published Indian and international evidences of it in IUGR and oligohydramnios. Dosage is 3 times a daily in as early as possible nasal onset of IUGR and oligohydramnios, and to be started from the day of the diagnosis of intrauterine growth restriction till you deliver the baby. Thank you very much, ladies and gentlemen, for your kind attention.
So I think, Dr. Shamal, you can stop sharing. We have Dr. Jaideep Tank, our chief guest for today's program. And Jaideep has been so kind to join even after finishing his exhaustive meeting with Government of India, and he's in the flight right now. But yes, we are very happy to have you, Dr. Jaideep Tank, who is the FOGSI president-elect and a very illustrious person. Jaideep has been always very, very appreciative and a part of all of my programs, I would say, as a committee chairperson. Thank you so much, Jaideep, for joining. And we are very eager to listen to your precious words. I know Jaideep has got a very exhaustive CV, but rather than this CV, I think we are eager to listen to you before you switch off your mobile. You can stop sharing, Bhavna. Yeah.
Thank you. Thank you very much, Sneha. I'm very, very sorry I got delayed. I just returned from London and then immediately had to come to Delhi for some kind of urgent meeting. Thank you very much for having me here. And let me begin by congratulating Sneha, who's the program director of this series and also is going to moderate a panel. Congratulations, Sneha. All the very best. You did such exceptional work as chairperson of the BREAST committee, and I do hope that we will see you in leadership position in FOGSI very soon. Let me also congratulate the ICOG office bearer and the MOGS office bearers, Dr. Sikande, Dr. Ashok Kumar, Dr. Pardesi sir, Nandita, Dr. Sujata, Kiran, and of course Sneha, and the conveners, Sumanji, who has been in touch with me constantly, Dr. Supriya Jaiswal, Dr. Indrani, And of course, the wonderful speakers, Arun and Shamal, dear friends of mine, wonderful chairpersons. Ajay, I can see you there. Hi. Dr. Nilakshi Hukan, Dr. Ganguly, and Dr. Apurva. And of course, you have a wonderful panel which will be moderated by Sneha. And you have wonderful panelists, Dr. Shelina, Dr. Indina, Dr. Saika, Dr. Mahanta, Dr. Arindam, Dr. Juspriya, and Dr. Sarvishta. It is also a pleasure and a privilege to be a chief guest alongside our very illustrious, eminent, and wise Dr. Gokul Chandra Das. I can't see sir, but please convey my best wishes to him. And of course, Sunita, who also I should wish all the best for the. Thank you again, Sneha, for having me. I'm very sorry I got delayed.
No worries.
And I wish you all the best. Thank you very much.
Thank you so much. Thank you so much, Jaideep, for your best wishes.
So nice to
And
see you,
thank you for
Jaideep. How are you? All good?
Very well, Shamal. Thank you. Very
So
much.
it's not even 6 months remaining.
Thank you.
Special thanks for joining and sparing some time for us. Thank you so
My
much.
pleasure. Thank you, sir.
Yeah, over to you, Suman.
Yeah, so we finished our first session, and Dr. Samal said it was brilliant in the management of IUGR. I think we all have been enriched. Now we come to the second session, and we have with us now Dr. Arun Madhav Barua. We are eager to hear from you. And your topic, we all know it is FCM, the final answer, and the chairpersons are already here waiting for you. So can I have the CVs? This session has to be taken by Dr. Indrani Roy. If she is here, she can take the session. Dr. Indrani, are you there?
Yeah. Do we have Dr. Indrani?
Yeah,
Suman, I think you can, is she there? Yeah.
Yes, she was.
You can take over. I think Indrani has written me a message that her network is very poor.
Okay.
But then, yeah,
Okay.
you go ahead
So
and
I want to have the CVs of Dr. Manjima Ganguly and Dr. Apurva.
Yeah.
It's a pleasure to introduce Dr. Manjima B. Ganguly. She is the CMO of ESI Hospital. Presently, she is Vice President of Guwahati Obstetric and Gynec Society. She has been the former IMA Dispur President and General Secretary as well. She is the member of National Mission Pink Health IMA, life member of IMA, and life member of Indian Menopause Society, and has presented many papers and has also chaired many sessions at national and regional conferences. Welcome, Dr. Manjima. And now can I have the CV of Dr. Apurva Bhattacharya, sir. So welcome, sir. Sir is Professor and Head of Department of Obstetric and Gynec at the Nalbari Medical College. He is the Senior Vice President of IMA Assam State Branch and also Vice President of SFM of Northeast Chapter. He has been Professor and HOD of Obstetric and Gynecology at Nalbari Medical College, UG and PG examiner of different universities of India, and has delivered and chaired scientific sessions in many regional and national and international conferences, and is involved in organizing regional, national, and international conferences, and has published in index journals and also in the postgraduate books. He is the founder, treasurer, and past secretary of ISOPARM Assam chapter.
Yeah.
So welcome, Dr.
Welcome, sir.
Yeah. So over to you for kindly introduce our speaker. Manjima.
Yeah, thank you for giving me this opportunity. I think my speaker initially was someone different, but anyway, Dr. Arun Madhav Barua is very well known to me. He belongs to our part of the world. He is the consultant, Apollo Fertility, Guwahati, and Apollo Hospital Unit, International Hospital, Guwahati. He has been the chairperson of NEIAG, peer reviewer in the Journal of OBGYN, India. He is the founder, chairperson of NESR, past president, Dibrugarh Obstetrics and Gynecology Society, senior vice president of IMA ASB, 2021 to 23. Vice President, East Society of Vaginal Surgeons of India. He is also an active Rotarian since 1995 He will be speaking on SPM. So we should waste no more time, and over to you, Dr. Arun Madhaporra. You can start your lecture.
Thank you, Manjima, for introducing me to the house. And at the outset, I must also thank the organizers, especially Sneha and the other organizers of the EMOG, for asking us to be a part of this particular program. And the topic that I choose today, because we were given a liberty to choose the topic, and that's why I thought using FCM for a pretty long time now, and I myself have used FCM for over 20,000 plus doses, and I must give certain inputs to my colleagues that it's time that we should really reach out to FCM in a much wider way than still we are doing now. While taking this subject forward, I'm sure I'm not going to take a long time, but we all appreciate being a gynecologist and being a care provider that iron deficiency anemia plays a very important role. Also, we should know that anemia is only an important manifestation. There are a lot of hidden things like an iceberg which we fail to recognize along with this iron deficiency. We all have read about iron pathway in the body, but the most important thing that we all need to wrap is the role of hepcidin and the role of ferroportin. And I'm not going to read it here line by line. We all must been upgraded, but have to understand the hepcidin plays a very critical role in the iron absorption. And that's why whenever the patients ask you, doc, can you give me a diet which will help me to increase my iron store from my regular diet? The answer is always should be positive and negative, because we just cannot commit. We can always give a standard diet that has been additionally benefits to our patient, but hepcidin level are not measured, and that plays a very crucial role always. We all know that this particular condition, in fact, starts in utero. And that's why when that particular girl is born and reaches the adolescence, she continues to be iron deficient and anemic, and the cycle goes on and on and on. By the time she turns out to be the prospective mothers, the status remains the same thing. So it's time for all of us to recognize this condition more vigorously and treat this more appropriately than in the past, because we all know that during last 35 years of our professional existence, we have used lots of iron salts, different medias to correct iron deficiency anemia per se, and a lot of other hidden symptoms which do not reflect iron deficiency anemia directly, but we have never measured iron levels in the patients on a regular basis. So pregnancy has been directly related to anemia, and anemia has been directly related to iron deficiency. And this has been proven in multiple investigations, multiple government reports, multiple reports by the professional organizations. But still, we all have to agree that almost half of OBGYNs prefer to change the iron salt when patients do not respond, instead of escalating or choosing or moving towards the parenteral iron. Yes, the choices are many. Every year, new salts are emerging. They are promising to be good. We prefer the words of mouth from our pharmaceutical companies, and ultimately, we sometimes, or mostly, do not end up on a happy note. Patients will say, the doc, I've not yet been benefited. I'm not here to teach you what is the definition of anemia. Again, that keeps on changing within the government of India definition, ICMR definition, FOXI definition. But to be on an uniform side, I think WHO's definition is quite loud and clear, and that takes care of everything that we need to know about anemia. So the causes are also known to us. I'm not going to again, but I just like to stress upon the physiology of iron balance during pregnancy is very pivotal, not only for the mother, but also for the upcoming baby that's been growing inside. As Syamal very nicely elaborated a topic called IUGR. So iron is also pretty important when pregnancy and anemia are in question. We need to replace minimum amount of iron to the mother so the baby in question really has an adequate storage and is coming to this earth with a good iron storage in the newborn. Otherwise, we would say that particular baby itself has been born in a deficient state, and that deficiency will seldom get corrected into her life. Now, when you look into the Indian diet are really iron deficient in comparison to the Western diet. But having said so, we can also enhance by vitamin C or any other lot of protein-rich diet can help you to increase your irons. But nutritional anemia continues to play a mammoth, and iron deficiency is one of the major roles in it. So this diagram must have been seen by all of you many times. So a lady in question really needs a high amount of iron because of constant loss during menstruation and also increased demand during pregnancy. And we need to take care appropriately so that she remains in perfect iron health throughout the region. Now, these are the factors that enhances iron absorption and also inhibits. I'm not going to again take it word by word. These all have been discussed. But what I'd like to stress upon you, that every time we take care of anemia, I think we are taking care of maternal morbidity and to certain extent mortality. And also remember, you are also taking care of the unseen newborn, which you are going to deliver with a good iron storage when the baby in question is being delivered. That is a very important step. As a prophylaxis, we are preventing that newborn coming to this world in an iron confident or iron stored perfection. So iron anemia contributing to the morbidity and mortality are again known to us. The consequences of iron deficiency anemia in pregnancy are enormous, right from the antenatal, interpartum and postpartum. And also when I was just talking to you about the fetal outcome. See, they all have a big role to play. So we have a tremendous role in preventing this. Yes, we all have made people aware at different forums, maybe by moving out to the social media from the professional side, making awareness camps, detecting hemoglobin. But today, detecting hemoglobin per se is not enough. I think we have to go a little beyond, look into the hemoglobin pattern, especially with so much of abnormal hemoglobin in this region, and also look into the most important component of the hemoglobin synthesis, that is called iron. So iron deficiency anemia is not only existent in a pregnancy, it is also very common in perimenopausal women who has a very abnormal menstrual pattern. And if you look into the main cause of this particular woman with abnormal menstrual pattern, you will see that they have a very low iron reserve, and thereby their hemoglobin level may be around 10 or maybe even 9, but their iron reserve will be extremely low because of abnormal bleeding and also from the poor dietary habit every one of us follow. So the role for all of us in managing iron deficiency, both in the form of prevention and treatment, is really very heavy. And we need to have a proper and a thorough idea and must act proactively to go a step beyond and see that we do not leave them untreated. Different strategies has been tried, like food enrichment, food supplementation, iron supplementation in the schools and colleges are known to all of us. I still remember since 1960s, the maternal and child health care has been going on, but the improvement in the real world has not been that proportionate to the existent programs carried out by the government and different organizations. We have taken care of hookworms, even malaria and other parasitic infestations, who are thought to be a very important cause of iron deficiency. And yes, still they are important in selected places within the country, but for an average person, they are not considered very important because these are going really out of the way in our day-to-day practice. The FOGSI recommendations stands tall in a FOGSI website. Any one of us who feels little more cravey towards treating iron can just browse through these particular recommendations, and they will also see that everyone needs to have a regular iron supplementation. And that is why we falter when it comes to the regular iron supplementation. We falter because we even do not take the medications on a regular basis. How can we expect our patients to do that regularly? We come to an particular replacement only when there is a need. Similarly, patients come to us whenever they suffer. So when they suffer, it's already too late. That's what I was trying to tell you, everyone. So different sort of dietary modifications have been tried. The heme iron, which is thought to be the most common iron preparation to get absorbed, are also being taken by our members, but at the same time, the results have not been really satisfactory. Vegetables, fruits, daily different colors are all being tried to motivate people at different point of time. Different motivation program, different modalities has been really put into, but the total need of iron is seldom met with for various reasons. So the modalities that we have in treatment of the iron deficiency anemia are oral iron, parenteral iron, and least I should say it should be the blood transfusion. But today, when we're talking about the oral iron, there is no ideal salt that would reach out to the way we want. Government is making its free supply abundant to every nook and corner of the country. Ferrous sulfate is a very good salt, but again, sorry to say, it is not being accepted well by the masses because of its fewer complications. Similarly, the newer salts that has been emerging into the market, we have also tried to use them. Again, it is not the one that suits everyone. So again, there has to be a cafeteria choice. Now, once it comes to the parenteral iron, the best part is you can be assured when you put the requirement after calculating the dosage into the patient, you can be sure the patient is not going to be iron deficient, and you have proven that the patient needs iron. And once you are sure, your treatment modality, your recognition of the need of the patient's health will really stand tall in front of the patient. So different salts being used, ascorbates, bisglycinate, ferrous sulfate, carbonyl iron, so many salts. Once upon a time, we used to say every AICOG Congress, we used to have a new type of salt. But ultimately, nothing is standing on a permanent basis for a long time. So indication for iron therapy should be known to all of us. Reticulocyte count is very important. Epithelial changes are seen on a clinical basis, but hemoglobin concentration should always be reassessed on a regular basis on a patient who needs this sort of therapy, because oral supplementation, if we just prescribe them, you need to take this for 12 months, just think that the patient will not take even for 12 weeks. So the problem with oral therapy really exists. Taste is not acceptable. Nausea, vomiting is almost a part of all oral medications. Constipation really affects almost 60 to 70%. Bloating and discomfort, heartburn, but none is present to almost all the ones. Every symptom is individualistic. If one has a metallic taste, they may not have an abdominal discomfort. So what I would like to say of this presentation that I'm showing to you, some of them, maybe two or maybe even one or maybe even more than two, can be existent when you prescribe an iron salt, and that can deter that particular patient from withdrawing your medication and further push the particular girl or the woman in question into more iron deficiency and anemia. So reasons are many, we know. The contraindications for oral iron therapy are also being known to us. But we have been trying, we are just trying to move on from one to the other. Now, why we should not move on to the parenteral iron therapy? Yes, we know the price has been one of the biggest factor, but with the competition going strong, the prices has really come down. Now, the major disadvantage of this parenteral iron therapy that I see today is it requires to be given in a hospital setting. Price has not been a very important factor to me as of now, because it is being achievable to around 70 to 80% of the masses. But what I see as a deterrent is only it has to be administered in a hospital setting, and that is holding the progress of this parenteral iron therapy. Different salts, different times, they have stood the test of time. previous salts had lots of complication, but today's the most preferred and the most widely used salt is iron carboxymaltose, what we call is FCM, ferric carboxymaltose. We can be given to the maximum of 1000 milligram in one go. Yes, we have iron isomaltose, which can be given to the 1500 milligram in one go, but very rarely our woman would need the 1500 in one go. 1000 milligram could be even on a higher scale, but 750 would be an ideal recommendation that would sum up as a average requirement for almost majority of the girls or women in question. So it is quite safe. I'm not going to take you exactly the different pharmacokinetics of these IV irons, but they are considered very, very safe, provided you follow the protocols and guidance given in this particular leaflets. Please make sure that you dilute that volume, whether you are giving 500, 750 or 1000 milligram, dilute that volume in 200 ml of 0.9% normal saline, and make sure that that particular volume is being infused to the patient in between 15 to 20 minutes only. If you are taking it beyond 20 minutes, the free iron radicals would really create certain issues. And if you finish it too early, again, the RE cells would not take up them, and their utility on a regular basis would not be achieved the way we are expecting. So if you are using oral iron, I think you should withhold this parenteral iron therapy for quite 48 to 72 hours before, and similarly for the same duration following that. Otherwise, I personally feel that iron deficiency anemia should be treated by parenteral iron if we do not have any contraindication. The contraindication again will stand because any drug would have an adverse reaction. So we should be prepared for anything and everything. But having known from different studies across the globe and within the country, and even during pregnancy, there has been studies from the All India Institute of Medical Sciences, Delhi, and from a lot of combined friends across the country, we have seen the safety of ferric carboxymaltose is tremendous, and there has not been any major, I should say, morbidity with ferric carboxymaltose. So we should actually widen our arms, accept these molecules, and see that our patients should be given this opportunity. Government today is really providing this FCM in few selected centers and trying to come up in a big way that they would see to eradicate iron deficiency in our country. Adverse effects could come to anything, but than adversity, we must have the adequate knowledge to tackle, and any of you would try to do that with your basic knowledge. So the regimes are also known. Just see that you have to apply and give the going to our patients. Having said so, blood transfusion today has not been on any particular requirement until and unless there is severe acute shortage of blood following a major loss. But even in those patients, when you are compensating the loss, there is an equal role of ferric carboxymaltose or other iron store to be replenished, because once your iron stores are adequate, the lady or the girl in question would stand a further chance of low blood volume to a great extent, because your store will be replenishing that lost amount of blood very quickly. And that is what we say. If you have a good iron store, your problem from hemorrhagic blood loss or even from hemorrhagic other conditions would not be that manifestive, as you have a good hemoglobin but no iron reserve. So looking at the hemoglobin today has been known to be a common man's job. So being a professional, you must add an iron store, and if possible, try to look into the hemoglobinogram of the patient, so that giving iron point blank to any one of them may sometimes falter, because in our region, hemoglobinopathy enjoys a very large proportion of patients. So they automatically have a very high iron storage by default, and pushing more iron into the system would really create a little amount of dangerous question, and we might have to give answer to that particular wrong decision. So transfusion should be prescribed only for conditions which there is no other treatment. As I said, adequate replenishment in a dire crisis. So I don't go to the bits, but some take-home point before I conclude. Iron anemia in pregnancy is really manageable, yet unmet health demand. Untreated iron deficiency has significant adverse feto-maternal consequences. Plethora of investigations are available for the diagnosis of iron deficiency anemia, each having specific advantages and disadvantages when used in pregnancy setting. Therapy for iron deficiency includes dietary modification, oral iron supplementation, intravenous iron, and very, very rarely or very occasionally blood transfusion. And most of the iron supplements are associated usually with constipation, dark and stools, diarrhea, loss of appetite, nausea, cramping in the stomach, vomiting, which limits a very less compliance for the oral iron therapy. So having said so, I think iron, especially the ferric carboxyl maltose, really stands tall amidst all modalities of supplementation whenever there is a need. And I'll be very honest to all of you to say, I always prefer this replenishment in front of my eyes so that my patients recover very fast and they maintain a good health. So I have used them in large numbers to say you that this is what is going to make your practice strong. Also, your patients would feel strong because their health is addressed in a perfect setting of iron deficiency. But remember, you are sure that that patient really needs iron. So you just have to add one investigation to your routine CBC, that is ferritin. Thank you so much for giving us this opportunity and for lending your patient time. Thank you.
Thank you, Arunda. It's a very wonderful to hear from you. Actually, in this very short time, you have finished the whole chapter of anemia along with the FCM, and you have given a clear message to everybody that FCM is the answer to most of our women, though we may have to investigate for hemoglobinopathies and other. I know that anemia is a very important, still important problem in our country. We have got a lot of problems by IMA, FOXI. We have been doing a lot of programs, but still we are not being able to rather fight anemia. There are Anemia Free India, Anemia Hatao, all programs are there, but still we are lacking behind. But this FCM is giving us it will solve most of the problems of our anemic mothers, not only pregnancy, but as you said, in a perimenopausal woman also. Because if you see, anemia develops from the child, whenever in womb, right from the womb, if the mother is anemic, the baby will develop anemia afterwards, and our adolescents are very prone to anemia for their diet also. And our women, they do not get the proper food. So nutritional anemia is very much common. I'd like to thank our organizers, the ABOX team, the Medical Disorder Committee, Dr. Sneha, Dr. Pardesi, sir, everybody, for giving us this opportunity, and we'll.
Sir, please unmute yourself. You got muted, sir. Hello, Dr. Apurva, sir. Yeah. Thank you so much. Thank you. Yes, Suman. Do we have Suman here? Otherwise, we go straight away to the panel discussion. So I just thank once again all the speakers, Dr. Arun Barua, sir, Dr. Shamal Seth. I thank all the chairpersons, Dr. Ajay and Dr. Nilakshi. I thank Dr. Apurva Bhattacharya, sir.
Thank you.
Of course, yeah, Dr. Manjima Ganguly. And with this, we go ahead. Yeah, so Suman, we go ahead for the
For the
panel
panel.
discussion?
Yes.
Yeah.
Yeah.
yeah. So
So-
just invite the panelists.
Yeah, I'll invite the panelists. Supriya is not there. Supriya was supposed to take the session.
Yeah. I would request not to waste time in my introduction.
Okay. So,
Please go
yeah.
straight to the panel.
So, I take the opportunity to welcome and invite our dear panelists. First panelist is Dr. Shailina CM. She is serving as second vice president of SOGS and has served in various rural and paramilitary forces for a period of 14 years. Very good. And at present, she is the visiting consultant to Bethany Hospital and Woodland Hospital. She has been faculty in various regional and national conferences and member of organizing committee of UA Foxy, NEOS,
Welcome,
and
Dr.
Northeast.
Shailina.
Now, Dr. Himlina Gautam, many congratulations. He was selected as the presenter from our East Zone, and she was in Ranchi. So, her area of interest is high-risk obstetrics, preventive oncology, and endoscopic surgery. And regarding her brief intro, she is best graduate 2010 from Guwahati Medical College and has received the highest post-graduation scoring in 2016 from Sri Manta Sankaradeva University. Now, Nilo Parna Saika, senior consultant with the Nazareth Hospital, Shillong, and executive committee member of Shillong Obstetrics Society. Next, please. Next, yeah. My friend, Dr. Pranamika, she is the secretary of Jorhat Obstetrics and Gynec Society, and she is presently assistant professor come superintendent of JMCH, and Dr. Aindom Bodhakur is director at Bodhakur Nursing Home in the Tinsukia at Assam, and his specialization in fertility and laparoscopy, and has presented several international and national papers in conferences. And Dr. Sarmishna Bhattacharya, she is consultant gynecologist at Silchar, faculty of AICOG at Guwahati and Bengaluru, and has published in Foxy Journal. So welcome all the faculties. Oh, now we have our friend Dr. Jupirika. She is a state trainer of TOT and MMA. Currently, she is secretary of the Shillong Obstetrics and Gynec Society, and she has been trained in advanced obstetric ultrasound, and her publications are in national and international journals. And she is the invited faculty in state and journal conferences. So welcome all. I think it's okay.
Yeah.
So now we go with the welcome moderator, Sneha Bhar madam, and all the panelists.
Thank you so much. Thank you so much, dear Suman, for introducing the panelists to me and the audience. I welcome all of you here. And without much ado, I'm so sorry for the delay because of various reasons. So I just welcome all of you once again here. And without much ado, I will straightway go to the panel discussion. So friends, when we are talking about the, maternal mortality, so we are always saying that these are not just the numbers and rates and ratios, but these are women, and they have their faces, which we obstetricians have seen or witnessed in their faces of despair and distress. And these are the faces which keep haunting our dreams. And so every woman and her face is very, very important for her. So women are dying not because of their diseases which we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. And we obstetricians are the one, we should take a keen interest, and we should take the initiative for saving our mothers. So hypertension, hemorrhage, and sepsis, these are the three major killers of the women. As I have said in the introduction, that in spite of the various predictive factors, the biophysical, biochemical predictors, in addition to clinical ones, we could not reduce the incidence of hypertensive disorders and the complications associated. But friends, let us now pledge that yes, we will try our best to do that. And with this, we start our first, the case scenario, how the patient presents to you and how should you evaluate her, predict her, and prevent the complications. So Dr. Shailina, welcome. I'm happy to know that you have had your education from MJMS Sevagram. So 22-year-old primary gravida belonging to a low socioeconomic status, and she has no known medical illness, no significant family history, antenatally booked, has an uneventful course till now. But suddenly at 32 weeks, you find that as a routine visit to ANC clinic, you find her blood pressure is 140/90. Would you label this patient as hypertensive? And how would you go about this management?
Thank you, madam. It's a great privilege to be in this panel, and thank you so much to the organizers of AMOX for including me. So in this case that we see, going straight to the case, I remember my consultants, they used to always tell us that what the mind does not know, the eyes will not see. So when you see this case scenario, immediately, when this person comes, there are certain things that should go through your mind, and you should come to the differential diagnosis before you go about. So I think coming to the differential diagnosis is important. And as you said, will I label this as a hypertensive patient? Like, according to the definition, we are supposed to repeat this blood pressure after 4 to 6 hours before we can make any classification and then place this person in the respective category. So having said that, the differential diagnosis, when we see this, it can just be a transient rise in BP. That is 1. 2, she can be a gestational hypertensive. 3, she can be a pre-eclampsia syndrome. 4, she can be the 4 and 5 are the rare ones. That is atypical preeclampsia and delta hypertension. The delta hypertension is hypertension which comes only in the 3rd trimester, not crossing.
Right. So I would like to interrupt you here, Shalini. Before going through the differential diagnosis, my first question is whether you would label her as hypertensive. So you have very correctly answered, and the message very well delivered, that you have to repeat the blood pressure after 4 hours. Okay, 4 to 6 hours, acceptable.
Yeah.
Only thing is, what the initial criteria for labeling her as hypertensive, whether for taking the blood pressure, you have certain criteria that how the patient should be mentally, physically. If you can throw some light on that.
So when the patient comes to the clinic or to the OPD or to the hospital, they're already stressed out. So it is important to calm down the patient, let her relax. And then when you take the BP, she should be in the sitting position and her hand should rest on the table. And then when you take the blood pressure, you have to listen to the 5th Karakoff sound. So till the time that the sound disappears, and that is the mark where you can make a correct judgment of how much is her diastolic pressure. So this is a way how you measure. And when a person comes to my clinic with this kind of history, I always go step by step. That is, we should always go from history, examination, that is the general examination, the systemic examination, and then you come to the investigation.
Yes.
So
very well discussed, Dr. Shalini. I would just say few points to be added here. The patient has to be mentally and physically relaxed, what you have correctly said. She has to, have her bladder empty. She should have, the comfortable clothings. The cup size should be well fitting, appropriate for her arm size. And of course, as you have very rightly said, the 5th Karakoff sound. Definitely, she should not have any, drugs before coming to the clinic, including even the eye drops. So that is what is very important. So very rightly you have discussed this. So for the next panelist, I would just ask a question, maybe Arindam, you can take up this question, that when you have this case as 140/90, would you label her as what kind of or what category of hypertension? And how do you go ahead for labeling or triaging this patient?
A very good evening, ma'am. So with the blood pressure of 140/90, after we have confirmed with a second reading, I would also like to do a urine albumin, a urine microalbumin, that is either a protein to creatinine ratio.
Correct.
If possible, a 24 hours urine sample.
Correct.
And if the urine sample 24 hours shows more than 3 grams, in 24 hours, and protein creatinine showing more than 0.3 milligrams per millimole, we can diagnose her as a case of preeclampsia.
Okay. Any comment on the severity of the hypertension?
Yes. So it is classified as mild, moderate, and severe. So the blood pressure from 140 to 150 systolic.
Yeah.
And
so I would
90
just interrupt you here, Dr. Arindam, that previously we had this classification of mild, moderate, and severe. But nowadays the concept is changing. You have only non-severe and severe hypertension. And how do you do that? And that is why I have asked you this question, that what investigations you would like to, what alarming symptoms, signs, and investigations you would like to look for in this patient to label her as severe or non-severe hypertension.
So when it comes to symptoms, I would ask her whether if she's having any headache, any visual disturbances like photophobia or scotoma or temporary blindness. Also whether if she's having any respiratory distress or any epigastric pain.
Yeah.
And whether how is the urine output, and whether a lab investigation, I would like to do platelet count, a complete CBC, including the platelet count, to look for if there's any thrombocytopenia, to look for her liver enzymes, especially her ALT and AST, and check whether it is more than 70, which is significant, and thrombocytopenia if there's less than 1 lakh, which is significant.
Very well said.
And also we'd like to do her kidney function test, her
Yes.
creatinine level.
Yes.
More than 1.1 is significant. There's a rise of.
Anything else you want to add, Dr. Nilotparna?
Also, we could check for her retina, look for any retinal changes.
Yes.
And these will show us whether we can classify as severe preeclampsia or non-severe.
Correct. So, do we have Dr. Nilotparna here?
Yes, madam.
Yes,
Good evening, madam.
perfect.
Yeah.
Good evening. So, do you want to add anything here? Suppose you have this 140/90 and these are the symptoms and signs. So, if this patient has 140/90 with these symptoms and signs, and there are, impaired liver enzymes and renal parameter, would you categorize her as severe or non-severe hypertension?
Yeah, if she has altered liver enzymes, then I'll categorize as her severe gestational hypertension.
Perfect. Very well delivered message. That don't go to the blood pressure level. It is the the various symptoms, signs, and the impairment in the lab parameters that helps you in triaging as severe and non-severe. So non-severe hypertension. So Pranabika, do we have Dr. Pranabika here? No. So Nilotparna, you only can go ahead with this patient 140/90. She has, one more question here. Does level of proteinuria change the diagnosis from non-severe to severe, or it has nothing to do with the severity? Because age-old concept was, proteinuria graded 1+, 3, 2+. So does it have any impact on the classification of severity?
Yes, madam. If proteinuria more than 300 milligram in 24 hours, or
significant proteinuria.
Yeah, it will be called proteinuria, and with 140/90 blood pressure, with proteinuria, we have to label her as severe gestational hypertension, madam.
Okay, you're right in a way, but the recent concept is that the amount of proteinuria, the quantity of proteinuria, and the fetal growth restriction, these are not considered as the criteria for labeling this patient as severe hypertension. That is what the concept by the World Gestational Organization. So this is because the proteinuria may be because of some different reason. That was their explanation. And even for FGR, it may be a small for gestational age baby or a constitutionally small baby. And that is the reason these two criteria are not included in the criteria for severity of the hypertension. So just let me know whether, so these are the laboratory investigations, all of you know, and all of you are doing it as a routine. So I will not go into the details. Considering the shortage of time, I would just ask you the question, Dr. Arindam, when do we start the antihypertension? Rather, when should we start antihypertensives?
So ma'am, once we have got 2 readings, a blood pressure of 140/90, more than 140/90.
Yes.
Ideal, and we get her blood parameters done, and we see there's a persistent elevation of blood pressure. Our goal should be her blood pressure should be 140/90 and below. That should be the
Yeah, so our
baseline.
patient has 140/90. So should we start
So
antihypertensive?
if there are other symptoms, and if there are other change of the laboratory parameters, we do need to start antihypertensive, because her baseline might be lower. For her, a one pressure of 140.
I would just remind you that you must have witnessed a patient of 140/90 also sometime convulsing.
Yes, I have.
Yes. So what does the evidence says? The NICE guidelines, they say that you have to start the antihypertensive when the blood pressure goes above 150 millimeter of mercury systolic and 100 millimeter of mercury diastolic. But the World Genosis Organization, FOXI and ICOG recommend, our own parent body, FOXI, and our academic body, ICOG, recommend that the systolic blood pressure of 140 and diastolic blood pressure of 90 millimeter of mercury warrants the use of antihypertensive drugs. Okay, so of course we have to monitor it very stringently to watch for the hypotension. So for severe hypertension, if there are no alarming symptoms inside, you may not give magnesium sulfate. You have to withhold magnesium sulfate, but you have to give the treatment of severe hypertension. So 140/90, even if it is 140/90, you have to start on antihypertensives. Which antihypertensives, that you have to decide now. For our patient, she's a non-severe hypertension if she doesn't have all these parameters impaired. If these laboratory parameters are impaired, this patient now becomes severe hypertensive patient in spite of the low blood pressure, that is 140/90, not low, but 140/90. So which drug we have to start, Dr. Jubirika? Dr.
Good evening,
Jubirika?
ma'am.
Yes,
Yeah,
yes,
yeah.
good
Am
evening.
I audible?
Welcome. Hi.
So, thank you, ma'am, for inviting me to be part of this panel discussion.
Yes.
So coming to the question, why labetalol? Now labetalol.
I would ask you the first question, which antihypertensive you start for this patient of 140/90? So your answer is, of course, labetalol. That is why I've just put you the question, why labetalol? And what other options you have?
Okay. So labetalol now is the drug of choice. Most of us are giving labetalol. Firstly, first is that it is the most acceptable with least side effects on the fetus, like no fetal effects, least maternal side effects as well, easily available, and it is free of, it has a rapid onset of action. So it's easily, we can give it easily. Yes. Second thing, the other options which we have is alpha-methyl dopa, which is the oral thing. But the only thing I would like to say here is that since most of us have started using labetalol, but in the periphery, like supposing our setup in our state, alpha-methyl dopa is still the first drug of choice in the peripheral setup. But we are gradually shifting to labetalol. Alpha-methyl dopa also is highly acceptable and one of the oldest drugs that is available with a slight maybe some side effects.
Okay. So, Dr. Sharmista, I would ask you, before this, I would just say that labetalol, you have very rightly discussed that it has got a rapid onset of action. It maintains the blood pressure very steadily. There is not much of hypotension, which may, alter the, it may just hamper the fetoplacental circulation. There's no tachycardia. And of course, there's, injectable form is also available if at all the patient develops severe hypertension. So, Dr. Sharmista, why not alpha-methyl dopa? Do we have some side effects which are really intolerable, and do we have side effects which we want to avoid? Dr. Sharmista, do we have Dr. Sharmista here? No. So I think Dr. Shailenya. So Shailenya, Arindam, Nilotparna, and Jupirika. Okay. So you can take up this question.
Yeah. So why not alpha-methyl dopa? Alpha-methyl dopa is centrally acting drug, but it also has an effect on the placental infusion, uteroplacental perfusion.
Correct.
And that's why you may have IUGR and oligohydramnios when you're using alpha methyl dopa. That's why we have shifted to labetalol, which has got fewer side effects.
Yeah, there are many reasons for alpha methyl dopa. I would tell you that when we 30 years back, when we were the postgraduate students, for us, alpha methyl dopa was the drug of choice and the only antihypertensive available. So the onset of action is so late. For 24 hours, there is absolutely no effect. So you give 1 TDS, 1 QID, next day you start increasing the doses, still you don't have, and suddenly you have a fall in blood pressure. So precipitous hypertension, and even the postural hypotension, that is a major drawback of this drug. The late onset of action and the postural hypotension. Also, the patient feels very sleepy, sedated. So maybe, it interferes with the feeding of the baby for the postpartum hypertension. When you continue it as postpartum also, it interferes with the breastfeeding. There's also some psychological effects. Maybe the patient gets confused and maybe, she gets severe headache. So you get confused whether these are the alarming symptoms for impending eclampsia or so. And also you have certain other side effects like, hemolysis, thrombocytopenia, and it also interferes with the Coombs test, it becomes false positive. So nowadays, at least, we do not prefer this. And for your information, it is not available in our state. Okay, so
also it causes postpartum depression.
Yeah, that is what we talked about, that it also causes postpartum depression. Okay. And then, of course, if the fetus is inside, there's some effect on the NST as well. So just a quick word from you on bed rest and salt restriction, and then we go ahead.
Yeah, there is no hard evidence that we should give bed rest to the patient, and salt restriction has not seemed to help these patients with HDP, especially bed rest. If you give bed rest to the patient, there is more increased risk of venous thromboembolism. So it is not advised. But you have to see patient to patient, because if you have a patient who's doing hard laborious work like a daily wage worker, then intermittent rest to advise to such patients is warranted. Otherwise, on the general form, bed rest and salt restriction is
So the message is adequate rest, that is 2 hours in the afternoon and at least 8 hours in the night, not the strict bed rest, which in fact will worsen the situation and may predispose this patient for thromboembolic phenomena. So friends, challenges are what make life interesting, but overcoming them is what life makes meaningful. So that is said by Joshua Marin. And this obstetrician for whom this patient landed up is from the older generation. She thought it is 140/90. And she just thought, it is a mild hypertension. She just sent her home because, 140/90. So no need to start antihypertensives. Next, after 5 days later, she was brought to her relatives with severe headache, nausea, upper abdominal pain. When you examine, you find that the blood pressure is 170/110. Her reflexes are brisk. She's got epigastric tenderness. Now, Dr. Himlina, how will you manage this patient? Dr. Himlina also we don't have, is it? Okay, so maybe Dr. Arindam and then Dr.
Yes.
Yeah, you can take up this question. 170/110, yeah.
Yes, so she has presented with severe headache and nausea. So she has the premonitory symptoms of eclampsia, impending eclampsia.
Yes.
And this is definitely
with severe hypertension. Yes.
With severe hypertension. So we definitely like to immediately admit the patient and start off with preferably injectable hypertensive like injection labetalol.
Correct.
And also if we need to start her on magnesium sulfate.
Perfect. So antihypertensive and magnesium sulfate, both have to be given simultaneously. Now, just let me know this patient has got this severe hypertension. So whether you label this as hypertensive emergency or urgency, and how do you do that?
Hello, ma'am. Hello,
Yes.
ma'am. Can you hear me?
Yes, Dr. Himlina, welcome.
Ma'am, I'm there, ma'am, but I think I was connected to the laptop. That's why you couldn't see me. I was there throughout from the first.
Okay. So please Please go ahead. 170, could you hear us? 170, 110 with all the premonitory symptoms. So tell me, dear, whether this patient has hypertensive urgency or emergency, and how do you label it so?
Ma'am, I would label, in fact, this as a case of imminent eclampsia because the features are going in favor of maybe she will need obviously immediate treatment of her hypertension. So
Yes,
for,
yes.
maybe an IV labetalol in this case, and then of course would like to do proper counseling regarding the fetus because it will be she will be around 33 weeks by this time, and like to start magnesium sulfate.
Yeah.
So that.
Yeah.
And then
So she's got severe hypertension. There's absolutely no doubt. But some patients you have to really try it, because if she has end organ damage, then she becomes a case of hypertensive emergency. So you have to really stabilize the patient and plan for delivery. But if this is a single episode of severe hypertension and her end organ, there's no end organ damage. So how do you do that? You have to send all these investigations. Okay, so once you have you hospitalize the patient, give her IV labetalol, give her magnesium sulfate as loading dose, you send her lab for all these parameters. Your aim of treatment is to avoid all these complications, because the moment the diastolic blood pressure goes above 110, you have so many complications, right from eclampsia, intracranial hemorrhage, pulmonary edema, and even the hepatic rupture, cardiac failure, so many complications. So your aim is to reduce the blood pressure significantly, but at the same time, you have to see that whether you can pull this pregnancy from this acute stage, whether you can continue this pregnancy ahead for the betterment of the fetus. Okay, so Dr. Nilotparna, what are the drugs available for the management of severe hypertension, and which one you prefer? What are the reasons? Please let us know.
Madam, drugs available are injection labetalol, hydralazine injection, then oral nifedipine is available, and for prevention of eclampsia, Maxalf. I personally prefer labetalol injection. So inject labetalol 20 milligram as IV over 2 minutes stat, and then blood pressure within again 15 to 20 minutes. If persistently high,
10 minutes, but yes, definitely 10 to 15 minutes. Okay.
Yes. Yeah, then if persistently high, we can repeat 40 milligram. Then again to 20 minutes. If again persistently 160, 110, then we can repeat 80 milligram. But after that, I think if it is not controlled, we have to think about second line. And simultaneously, if she is having pre-monitoring symptoms, we have to start Maxalf.
Yes, perfect. So we agree, all of us agree with you that yes, labetalol. But how much labetalol maximum you can give?
Maximum, madam, 300 milligram.
Milligram can be given in over 24 hours. Yes, perfect. That is what the answer. Suppose, I mean, this is not effective. What other options do you have for the intravenous injections as well, or maybe the oral therapy?
Yeah. Intravenous, we have, madam, hydralazine. Hydralazine. I personally don't have much experience with hydralazine. But book says 10 milligram IV stat. Again, repeat. You can repeat after 15 to 20 minutes. But if 2 doses of hydralazine BP is not controlled, you have to add labetalol. And nifedipine oral 20 milligram. Then orally stat followed. Repeat BP again after 20 minutes. Then second dose of 20 milligram nifedipine you can start.
Yes.
Yeah.
So our aim of lowering the blood pressure should be such that there should be no sudden hypotension.
Yeah.
Only 10 to 15% of the mean arterial pressure should be reduced. That means the blood pressure should be kept at initially between 150, 100 to 140, 96. So that is all. Maybe we can just say 150, 100. That should be our aim of treatment. We have to keep the blood pressure optimally. We have to bring it down slowly to that optimal level. So very well discussed. The injectable labetalol is the drug of choice, but we do have injection hydralazine. And of course, I can share with you that we have used on some of the occasions when you have the malignant hypertension or even, 120, 130 plus when the diastolic blood pressure goes, you have no option but to subject her to NTG drip, that is infusion, the micro infusion, or maybe sodium nitroprusside infusion also you may have to give. Commonly, we can manage with IV labetalol and oral nifedipine. We have been using oral nifedipine even till today. The capsule nifedipine, which is the oral orange color capsule, which is available as 10 milligram capsule, you give it immediately. The onset of action is within 5 to 10 minutes, and the peak action is achieved within 30 minutes. And the duration of action is 6 hours. So with one capsule 3 times or 4 times a day, you can have a very good control even in the severe hypertension. Maybe sometimes if the blood pressure is very high, you may have to use 20 milligram or so, that you have to titrate individually. So the lowering of the blood pressure, I've already shared with you that it has to be lower only 15 to 25% of the mean arterial pressure, and small reduction in blood pressure over 60 minutes. It should be, 150 by 100. So 170 by 110 to 150, 100. Only this much should be done. And the reason being, the fetal vasculature is adapted to this high blood pressure. And if you try and reduce the blood pressure suddenly, then in fact, there is a chance for hypoperfusion and fetal jeopardy. And that's the very reason we are supposed to be very cautious as far as the lowering of the blood pressure is concerned. This is what the chart you have very nicely discussed. And the only caution from my side, I'll be telling you that in a hurry to lower the blood pressure suddenly, you're worried that maybe the patient will convulse. For that, you are giving magnesium sulfate, but don't be in a hurry to lower the blood pressure and give this capsule nifedipine sublingually. I would say giving capsule nifedipine sublingually is a crime because, the patient have collapsed and died of this treatment. So that's a very reason it has to be capsule nifedipine orally with water. We have to ask her. Now, other drugs, these are a few newer drugs which the physicians and cardiologists are using quite frequently. Nicardipine is a very, very promising drug which is coming up in over few years. It is available as, it is 100 times more soluble than nifedipine, and that's the reason it can be administered intravenously as well. So this is also a calcium channel blocker, and of course the onset of action with an intravenous nicardipine is between 5 and 15 minutes, and the duration is same as 4 to 6 hours. So this is also a very promising drug. And other drugs like osmolol, the ultra short acting cardioselective beta adrenergic blocking agent, and because of its pharmacokinetic properties, some authors consider this as the ideal beta adrenergic blocker. This agent is available for IV use, both as a bolus as well as infusion. So although osmolol may be useful for therapeutic agent in obstetric and obstetric anesthesia, concern about fetal safety have limited its use. So it can lead to persistent fetal bradycardia. And if at all the patient has received the drug, we have to inform the neonatologist. So I think Dr. Pranabika has not joined as yet. So I think the next person can take up this question. Whom do we have now? Shailinia, I think, yeah, Himlina, you can take up this question. What other clinical, suppose you're managing this patient, you have taken us through monitoring the maternal well-being, you have done high investigations. When the investigations are normal, you have to just repeat it every weekly, but when they are impaired, when they are abnormal, you have to repeat it quite frequently, and that is every 3rd day. So you have taken her through this course of pregnancy very well, and you're trying to go for the expected management. What are the clinical findings which would, make you warrant your termination of this pregnancy? Yes, Dr. Himlina, please unmute. All of you can unmute yourself and you are free to discuss.
Ma'am, first of all, if we will have to follow up this patient, admit her and, give her proper antihypertensive, if her hypertension is not
Our
being
patient is admitted, my dear. She has had that severe hypertension and we have given her IV labetalol and we have stabilized her. Maybe we are just trying to shift her to oral antihypertensives. And till now you are through.
Yes, ma'am. So if the hypertension is uncontrolled, with even with the adequate medications,
That
then
is one indication. Yes.
And she has got abnormal neurological features like infectable headache, blurring of
But do
vision.
you all agree to this indication that when the hypertension is not controlled with 2 more drugs, you can add 1 more drug. You can add
Up to three drugs.
yeah.
Up to three drugs.
So that is not an indication for termination of pregnancy, I would say. Okay.
She starts developing her liver enzymes start rising. Her creatinine again starts rising. It is more than 1. There is oliguria, or she starts developing pulmonary edema, or the oxygen saturation has fallen down. And of course, I mean, if there is any evidence of abduction or fetal heart rate is
this you have discussed for the mother. What are the fetal indications for termination of pregnancy?
Ma'am, again, a non-reassuring fetal heart rate, or with the doctor, we do in this case, so it is showing a reverse and diastolic flow, or there is abruption, then we will.
Abruption, you have no choice but to deliver her. Perfect. So, as you have rightly said, for the mother's side, when she convulses, yes, your blood pressure is not controlled, but you are trying your best, but she convulses. So not to take this chance, we have already given her magnesium sulfate. But if she convulses or she lands up into abruptioplacentity or HELP or acute renal failure, as you said, pulmonary edema, and of course, this fetal jeopardy, what is observed on ultrasound as absence or reversal of end-diastolic flow. So these are the criteria for termination of our expectant management. Correct. So what? Yes.
Ayaw to
Yes, Dr. Shailinia. So, and Dr. Arindam, now we come to you. We have given this patient the prophylactic Maxel because she has not convulsed. So we label it as prophylactic Maxel. So for prophylactic magnesium sulfate, how do you give, what dosage, what regime do you follow?
So, ma'am, there's of course a role of prophylactic Maxelf, and I follow the Pritchard regimen. But for prophylaxis, I usually do not give the IV dose. That is, I give the IM dose, but also it depends upon the weight of the patient. If I see a patient which is not well built, that is, I don't give the full Pritchard regimen, that is 5 grams IV and 10 grams IM, then followed by 5 grams every 4 hourly. That's there in the recommended thing. But we go on the lower range, that is 4 grams 6 hourly intramuscular.
So though friends all over India or maybe all over world, we individualize our dosages and regimes as per our practice and experience. What does the evidence say that whether it is a prophylactic or a therapeutic magnesium sulfate, it has to be a complete Pritchard's regime, one or maybe the Zussman's regimes, but there's no difference in the dosages and schedule as far as the prophylactic or therapeutic magnesium sulfate is concerned. That is what the take-home message is. So when you are giving Pritchard's Max Sub regime, yes, 14-gram loading dose. So you give 4-gram diluted magnesium sulfate. All of you know that because you have been doing it. So 4-gram is 8 ml. To 4 ampoules of 50% magnesium sulfate. So that is 8 ml. You dilute in 12 cc distilled water or normal saline, and you give it slowly over 5 minutes. Of course, you have to monitor all your vitals, and then you give deep intramuscular 5 grams on each buttock. So 10 plus 4, that is 14. That is for initial. Meanwhile, you monitor the respiratory rate, the deep tendon jerks, and the urine output. The urine output has to be 30 ml per hour minimum or optimum, I would say. You repeat the dosage every 4 hourly till 24 hours, from the delivery or last conversion, whichever is later. So at least 24 hours you need to cover. Meanwhile, you monitor all these things. Whenever you have even slightest reduction in the reflex also, if the reflexes are not elicitable, the recommendation is to withhold that particular dose of magnesium sulfate. If at all you have the urine output, which is very, very less, not up to your expectations or not what is recommended, not even 25 ml per hour over last maybe 4 hours. If it is less than 100 ml, then only you have to stop giving magnesium sulfate dosage and you have to do the plasma magnesium sulfate levels, plasma magnesium levels. Okay, so in my 30 years of practice, when I've been using this magnesium sulfate routinely for all the cases of eclampsia, there's not even a single case of maximum toxicity. So that's why, even though this is a drug which is described as having a narrow margin of safety, it doesn't cause toxicity so easily. We have all these parameters to monitor. Things can go wrong only when you are not monitoring these parameters and you are not taking the cognizance of the adverse parameters. Okay, so that is Pritchard's maxim. Similarly, Zuspann's regime, you give 4 gram. Anybody wants to describe this? Zuspann's? Yes, Shalini. Yes.
You take 4 grams, 4 grams of 50% Maxolf, and you again dissolve it in 12 cc of distilled water, and you give it at 1 ml per minute over 20 minutes. And otherwise, the loading dose can also be diluted in 100 ml of 100 ml of saline and then given over 20 minutes. That's also acceptable. And the maintenance dose, you take 12 ampules. That is 12 grams of Maxolf, and you dissolve, that will be 12 grams will be actually 24 ml. So that 24 ml, you dissolve it with 26 ml of distilled water, and that will give you a total of 50 ml. And that you have to give it by infusion pump at the rate of 4.2 ml per hour. So that will give 1 gram per, per hour. Yeah.
Quite complicated, I would, though theoretically correct, Selenia. So what I would suggest you to follow this regime, very simple method, I would tell you, what I have been writing here. When you give initial 4 gram, then you give 1 gram per hour. Okay, so you have a pint of 500 ml, you just add 5 gram Maxolf to that. So 1 gram per hour is 100 ml per hour, correct?
Yeah.
5 gram in 500 ml. Okay. 5 gram magnesium sulfate in a pint of 500 ml. So that goes 1 gram per hour, that is 100 ml per hour, very simple. But in these cases of, preeclampsia or eclampsia, we want to also have, fluid restriction.
Yes.
We don't want to give lots of fluid. Yes. So here we have recently, one of the pharma, they have launched a 100 ml concentrated solution of magnesium sulfate for infusion, which is to be given. So that is also very simple to use and very effective as well. So that is about the magnesium sulfate regime. So basically you have to give it, you have 2 purposes served here. One is the mother's eclampsia or convulsions, that is to be taken care of. And secondly, the neuroprotection of the baby. Even if at all this baby you need to take out prematurely, when you are preparing this baby, because you are already on expectant management. So you're giving injectable steroids, you're giving magnesium sulfate. So you're taking care of the lung maturity and you're taking care of the neurological side effects, whatever of the prematurity. So I have already discussed this point actually. Do we have Jupirica here?
Yes.
Jupirica?
Yes, ma'am.
Yes, please go ahead. At what gestational age you would deliver this woman?
Okay, first of all, we would like to label her as severe or non-severe hypertension. It is a non-severe type of hypertension.
We have already brought her till now. She has been monitored, managed as a case of severe hypertension. Yes.
So now, if she has reached
now she's
34
stable. So how long do you want to pull her?
So if she's stable and all her blood parameters are not deteriorating, her symptoms are not deteriorating, and she's stable, and also after the fetal monitoring is stable, I mean, there is no abnormalities in the ultrasound findings or NST, we would like to pull her up to 34 weeks.
Perfect.
34 weeks and beyond.
Yes, that is what the message we want to give.
Yes. But in case if any of the parameters derange any time, the maternal or fetal. So
yes, that we have
maternal,
discussed here, that yes,
that is right.
if there are
Then
any, yes.
So if
Go ahead.
any, then yeah, ma'am. So if after the completion of the dexamethasone, then I think we should terminate the pregnancy.
Yes, perfect. So the message here is when you're managing such a severe hypertension, even if you have stabilized her right now, you have prepared the baby, and this is the right time when she completes 34 weeks. You need not be, very greedy to pull her to 37 weeks, because anytime she may land up into end organ damage, anytime she can have abruption. Okay, anytime she can land up into sudden severe uncontrolled hypertension, or she just throws a fit without your knowledge. So that is how. So when you have severe preeclampsia before 26 weeks, your aim should be the mother's life first. You have to just stabilize the patient, evaluate, monitor, and just plan for termination of pregnancy. If at all you try for, if you have a very good NICU, you may just try for the baby. But 26 weeks less and less, it should be maternal life first and termination of pregnancy. 26 to 34 weeks is the time with what we are discussing, that is the expectant management, and deliver only on fetal or maternal indication. You pull on till 34 weeks, stabilize the patient and deliver. We have already discussed this, what intervention you do for improving the neonatal outcome, that steroids and magnesium sulfate. But then I will just go ahead. What anesthesia? I think we will just have few points here. What kind of anesthesia you would like to prefer for this woman, if at all she lands up into cesarean section? What anesthesia? Himlina? Yes.
Regional anesthesia will be preferred. I think a spinal or a spinal epidural anesthesia will be preferred.
What are you doing as practical point of view, and what is ideally you should prefer? You can talk of both things.
We all go for regional anesthesia, ma'am, provided the platelet count is more than, at least we take it as in our setup, we take it as around 70,000, 75,000, but I think less than 50,000 never should be given regional anesthesia.
Okay.
And most of the cases, otherwise, if the patient, in very severe hypertension, we sometimes give general anesthesia as well.
Okay, Shalini, you want to add something? Yes.
Yes. Since we are discussing this is a severe case of preeclampsia, so platelet is very important. So just saying regional anesthesia is not going to solve the problem, because if a platelets are low, then that's a problem. So if she's having preeclampsia with impending signs of eclampsia especially, I think general anesthesia is the option.
Yes.
Also, ma'am, I guess we have to take in count about the window period, that since we have already administered her Maxelf, there is a wait time of at least 2 hours, they say, we should, before giving anesthesia, because Maxelf can act as a uterine relaxant as well.
Yes, yes. Very correct. So, and we have to inform our anesthetists about the drugs what we have given, right? So, they can interfere with the anesthetic agent as well. So we have to be cautious about that also. So preferably, see, as a practical discussion, when we talk about, Shalini very well pointed, you pointed out the platelet count. So if everything is fine, even if you have this hypertensive lady, if the platelet count is good enough, you are taking up for cesarean section, then I think preferably regional anesthesia, that too epidural anesthesia should be preferred. But if not, spinal anesthesia is also. In certain conditions where you have very severe hypertension with, you are suspecting some cardiopulmonary problems, the general anesthesia should be the best one. Now, of course, general anesthesia also has its own problems, like, uterine relaxation, excessive bleeding, what it happens. But the anesthetists feel that they have a good control over the patient. That is what their comfort. So I think we leave it to the anesthetist. That is the best answer, I would say here. So now I was talking to you that this patient landed up with the old kind of obstetrician, So she thought, she's very good and she's doing well. Everything is fine. BP is controlled. So now she thought of going beyond, 34 weeks. and suddenly you find that the patient started getting severe pain in abdomen, headache, and she started having little spotting. So when you examine, you find the blood pressure again shoot to 170, 110, DTR is pressed, the uterus is tense, tender, and the fetal heart is 110 to 120 only. And yes, there is little bleeding and the station is high up. What do you feel that what complications she has landed up into, and how would you go ahead?
Yes, madam.
Yes.
Yeah, this
yes.
Yes. Considering her condition, her blood pressure is so high. She is having pain, abdomen, tenderness of abdomen. She is likely to have developed abruptio placentae. So this patient, if blood pressure is little well controlled, I would have liked to do an ARM and augment her for normal delivery. But since her blood pressure is so high and she is having premonitory symptoms, I'll prefer doing an emergency infection.
Do you all agree to Dr. Nilotparna what she's saying? 2 finger only, my dear. The station is high up. You're not sure about the delivery, which is why you want to put the baby at risk.
Also, there's fetal bradycardia.
That's what I'm saying. She's already even if she was not having hypertension and blood, the fetal heart of 110 when she has fetal disease with floating head, 2 finger, it's a straightaway indication for cesarean section. All of you agree to me? Even without hypertension, when you get a patient, when you get a patient for labor and you find that her fetal heart is only 100, 110, okay? Dr. Shalini, I'm especially concerned for you that when you have fetal distress, the head is floating and she's not going to deliver soon. So cervix is only 2 finger loose. Do you want to wait for her delivery?
No, I beg to differ here, ma'am, because she's two finger loose, but we have to know the Bishop score. If it's a very soft cervix, 2 finger loose, she has abruptio. If you do ARM, the labor is going to be very fast if she's going to progress.
Yes, she's a primary gravida. Mind well, she's a primary gravida.
Primary, but she's hypertensive. Usually, if you're hypertensive, you have given these Maxaf and all, it makes the cervix soft. So the chances of it coming out is also there. And once it contracts when you do ARM, that abruptio is also compressed. So the bleeding is also like controlled, but you have to have CTG on the patient.
The same discussion we take forward that suppose, you just do her ARM. Do you know that for a fetal floating head, when you do ARM, when there was no previous abruption, that is one of the causes of abruption. Do all of you agree to me?
Yes, madam. We have to do a control
it is called as abruptio because of sudden decompression, right, Jupilika?
Control.
Okay. So when our patient already has abruptio, which may be minimal, with your ARM, it's going to, the whole of the placenta may separate. Okay, practically, if it was 5, 6 or 5 to 7 centimeter, I would have been fully agreed to all of you, right? So it's only 2 finger. She's primary and floating head. I don't think this is totally injustice to the woman and to the baby as well. So very simply, fetal distress is straightway an obstetric indication for cesarean section. We have every right to do for cesarean section, right? So save the mother and save the baby both. We are not heroes. We're not going to get gold medals from neither the government nor the relatives. So be very practical, my dear, and you protect the patient, protect yourself as well. So take an informed consent that this is a situation and we have no option. If at all you want to wait, she's not ready, you have every right to write from her that I'm not ready for cesarean section. And then you make yourself safe. Okay. So here the clear-cut answer is fetal distress because of abruptio placentae and the delivery is not imminent. You have to go straightway for the cesarean section. The complication here is abruptio placentae. Look at the lab parameters. Platelet count is 50,000 only. Bleeding time, clotting time is okay, but the fibrinogen is 150 mg% only, and there is FTP present.
She's going in for DIC.
Yes.
So definitely we'll arrange for
blood and blood. Section first, or you will arrange
for blood and blood products, ma'am.
blood.
We'll arrange for blood.
Simultaneously, we'll
And
have to do
simultaneously.
it.
Simultaneously.
Perfect. So it has to be a very, dire emergency. You have to call for help, assemble all your staff and even your team as far as the anesthetist, senior obstetrician, senior anesthetist, the blood bank and the neonatologist, everybody you assemble and try and collect the blood and blood products as soon as possible. Try and start the blood and blood products as soon as possible. And by the time you start doing the cesarean section, so that you have good control over the situation. And yes, when you have abruptio placentae with platelet count of 50,000, this is a patient not to relax even after delivery of the baby. She is the one who is likely to go for postpartum hemorrhage. So that is what we have to assess. So this was about the slide which was there for anesthesia. So the contraindication to regional anesthesia is only when the patient is actually in DIC and very low platelet count, and when she is status eclampticus, when giving anesthesia is not possible. That is not actually a contraindication, but it is not possible. So you give general anesthesia so that she is relieved of the status eclampticus. Okay. DIC score, does anybody want to speak on this? You have to just remember that there are various parameters to be considered. They are platelet count, fibrin markers, that is FTP and D-dimer, and prothrombin time and serum fibrinogen. And according to the levels you have to score. If you have a score of more than 5, then it is a overt DIC. If the score is less than 5, then it is a non-overt DIC, and you have to keep all the blood and blood products ready. How to decide on the individual blood and blood component, I think we will require one separate session for that as massive transfusion protocol. So I think we will just end by this slide, that this patient who was constantly having headache, you have given her Maxal, she has not convulsed, but in spite of that, she's having headache only. So when we sent her for ultrasonography and MRI, she convulsed on the way. Okay, so the MRI showed this picture, what I have been talking to you about, the high signal intensity bilaterally parieto occipital white matter consistent with the vasogenic edema. So this is what it is called as PRES, posterior reversible encephalopathy syndrome. The matter of fact is, to relax here, is that it is a reversible condition. So but we need to actually make the diagnosis right from the beginning. We have to be little have a high index of suspicion, try to avoid complication, be very supportive, and try to reduce the intracranial edema with the help of the neurologist. And of course, we see to it that it usually recovers within a week or so. So need to be recognized promptly. It is reversible, as I have already said. Delay in the treatment may result in permanent brain damage. Even certain retinal problems also can happen. So immediate delivery or discontinuation of the cyclosporin treatment, what is recommended here. So friends, crisis is an integral part of human life, and those who timely and appropriately contract it will survive and succeed. That is what Gita says, not me. So with this, I end my presentation. All of you know that prediction, prevention, and preparedness is the key to success of managing our patient. All of us pledge for saving our mother's lives. And of course, we have very good take-home messages. All the panelists, you all are very interactive, and I'm very happy with your contribution to the session. So with this, friends, I thank all of you, and I humbly appeal to all of you for my candidature as FOGSI Vice President from West Zone. And I request not only your vote, but I request your wholehearted support for my candidature. And I hope that I deserve your support, and definitely I will work for FOGSI and FOGSians. That is a promise from my side. Thank you so much. And over to you, Dr. Suman and Dr. Supriya.
Thank you, madam. Thank you.
Yeah, if
Thank
any
you.
panelists and chairpersons, anybody is here want to make some comment. Dr. Shailinia, can we have few comments from you? Shailinia, Jupirika, whosoever.
Excellent presentation, ma'am. I think HDP is one that we face in and out every day, and I think it's one of the killers and a very important topic to refresh our minds and to update. Thank you very much for your excellent presentation.
Thank you, my dear. Yes, Jupirika, any comments? Simlina, yes.
Thank you, ma'am, for making me a part of this webinar today. All the topics, the FCM and IOGR, really, it was a good brushing up of all the latest evidences and guidelines, and especially HDP. I'm working on it. I have also written a chapter along with Dr. Sashwati, ma'am. So I'm really happy to be a part of it, ma'am. And
yeah, I'm really missing Dr. Sashwati. Somehow we could not communicate with her. I tried calling her. I think she was in some remote place of Arunachal Pradesh. And in fact, you please convey my respect and regards to her. We would definitely have her in some other session. Thank you. I can see Dr. Arun sir and Apurva sir. So can we have your comments, sir?
Obviously, everybody was looking into and glued onto the program. The discussions basically help us to enhance our own knowledge and also learn from others to enhance our day-to-day.
Correct.
So whether it is a common topic or an uncommon topic, I think any sharing of scientific information between a group of persons or between two persons is always beneficial as a professional. If you're interested to be in a field, I think as a professional, you need to enhance your scientific boundaries, and that is the best modality. You can do your job, still enhance your knowledge to great extent. And these are the platforms where you have decided that to allow us to be a part of it. So it's our benefit, and thank you so much for allowing us to be a part of the program.
Sir, it's my pleasure to have you as a speaker, sir. And you are such a illustrious speaker and lots of information. And I'm so happy that as Medical Disorders Committee Chairperson, I'm covering all the aspects of medical disorders, and very happy to have your contribution as well. Thank you so much, sir.
Thank you, ma'am.
Yeah.
Thank you, ma'am, for having us today in this webinar. Also, I'd like to thank Arun Madhav Barua also, sir. He's given an excellent presentation on FCM. It was really enlightening, and like everybody else said, that HDP is one of the very important topics and is very important for us to update every now and then. Anyways, thank you for having us, and being the secretary of Shillong Obs and Gynae Society. I'd like to thank you on behalf of the society for letting us be a part of this webinar today. Thank you, ma'am.
Thank you so much, my dear. Thank you. In fact, Indrani was constantly in touch with me, but she was at some remote place where there was lots of issues for the network, and she could not be there for the program. I mean, she could not stay back here. So, Dr. Arindam.
Yes. Thank you, ma'am. Thank you so much for giving me this opportunity, and it's a real pleasure and it's an honor to share the platform with you and all the other seniors here. And it is such a great education experience, and learned so much during today's, and even the speakers who were there. Thank you, ma'am.
Thank you so much. In fact, I always wish to be in close contact with the Northeast societies. Dr. Gokuldas sir from Assam, I know him since long time, almost 2005. And he knows me. We have been together as faculty since then, 2005 in Pune, Mumbai, and all over Maharashtra. But definitely, Dr. Indrani, who was my committee, she was a East Zone coordinator. So she was very much in touch with me, and because of her, I came to know all of you. And because I'm trying my best to do good for the FOXI, the organization, as well as the FOXians as well. So I just humbly request you for your votes and your precious words to be spread in amongst the society members for me as my candidate for FOXI Vice President. And please do vote positively. It's between 1st to 10th August, and it's coming soon now. Thank you so much. Thank you, sir, Dr. Apurva Bhattacharya, sir. I could read your message. If you are here, sir, please.
Thank you. Yes, sir.
Thank you so much. Thank you. Thank you so much. And once again, I thank everybody. Yes, Supriya, over to you. Yes, Jupirika, you want to?
Thank you, ma'am. No, that. Thank you, Apurva sir, also. Sir, I could not say.
Yeah. I'm very much
Yes,
happy
sir.
to see you all.
Thank you,
See you.
Apurva sir.
Excellent.